Bless you. All right. Good morning. It'll cool down here in just a few minutes. Good morning. Okay. Have you guys been getting the wrap-up emails after class? No? Okay. I'll have to look at that. I know I had some problems with class 1, so I'll have to make a note. So, wrap-up emails. I'm going to have to set it up again because apparently there's an error. I'm sorry. I'll make sure that you get the wrap-up emails from last week as well. Sorry about that. All right. Did you guys do your homework over the weekend? You had 2 chapters, chapters 2 and 3. So on the tests are going to be pages 182 and 183. Okay. Did everybody grade your tests using page 201? If you did not, when I call your name, just say pass and I'll get your scores next class. Okay. If you graded it and you know how many you missed, or if you know the percentage that you got, let me know and I'll write it down. Ada. You're still grading. Okay. Zumarenda. Do you have chapters 2 and 3? Did you grade them? Did you grade chapter 2 and 3? How many did you get wrong? Okay, I'll see you after class. It's fine. Elvira? What? 0. Okay. Thank you. Robin? Okay. Samantha? On chapter 2? What about chapter 3? Okay. Thank you. Janiyah? Thank you. Catherine?
Chapter 2, I got 1 wrong, and then chapter 2, I got 2 wrong.
Okay, very good. Jihu?
I have to grade it.
Okay, that's fine. That's fine. Paula?
2, 3, and 50.
Okay, that's fine. Kaylee?
I got 1 wrong on chapter 2, and I didn't do chapter 2.
Okay. Brianna? Okay. What's your name again? Okay. Thank you. Brianna? Is Brianna here? Luz? Kiara? Thank you. Cheyenne?
95 on 2 and 90 on 3.
Thank you. Do you have 1 for me by any chance?
Yeah. I didn't grade it.
That's fine. That's fine. On the front of your yellow book, what is the number? It's Y something. Thank you. Okay, Tamika? Jody?
0 on both.
Thank you. Abigail? Okay. All right. Let me see here. Oh, the sound is a mess? Oh, no. Let me see here. Testing, 1, 2, 3. Testing. Is the sound not working, guys? Put in the chat if you're having sound difficulties. Can somebody let me know? Okay, those of you who are online, just put in the chat whether you can hear me or not. Okay. While I'm waiting for that, we'll move on. How do we know what to do with each person? We follow the care plan. Not just the care plan, it's the care plan, the whole care plan, and nothing but the care plan. While we're doing that, what else should we be doing? What with the patient? What are we there to do? Observe. So we're going to make observations. And then who do we report those to? The nurse. Very good. Good morning. Raz, can you hear me? Is the sound coming through okay? Sound is fine. Okay, good, good. All right. Thank you. Thank you, guys. I appreciate that. Okay. Great job. So every skill starts with the opening. Every opening starts with a knock, right? And remember that when we're practicing in here, it's really easy to just kind of skip over the opening and go right into the skill. But the way you practice is going to be the way you perform it when you're testing. If you're not used to doing the opening, when you go to test, you'll just totally skip over the opening. And if you remember, the opening and closing makes up half of your skill grade. So when you're in here practicing, make sure you're doing the opening as well. That way you get used to saying it. It becomes part of the skill and you're not, you'll have a better result on the test. So knocking is important. After we've knocked, we're going to greet the patient. Yeah, it's all about the patient. And that's what these two steps are all about, is to remind you in your mind that this whole thing is about the patient. So knocking is informing them that we're coming in. Greeting them is playing nice, basically. Okay, we have to remember that it's not about us and the tasks we have to do, and it's all about the patient. So make sure you take that greeting kind of seriously. Good morning. Good afternoon. I always, somewhere in there, try to ask, how are you? We're going to address the resident by, how do we address the resident? By name. Some of you are going to have trouble with this, especially, do I have any servers in here? Former servers? Okay. When you're a former server, you tend to use honey, sweetie, darling, all of those endearments. And we're trying to get the tips up, aren't we? So if you are a former server, this may be a little bit hard for you to change these habits. We're not trying to, we don't want to use endearments. We want to be professional. There's a big difference in how patients perceive the interaction. We want to be professional. So we want to use that patient's name. We do not use honey, sweetie, darling, dear, sugar plum, any of those. We're going to keep it to the patient's name. We're going to introduce ourselves by name and title. Yeah, what are you? We're going to tell them what we're going to be helping them with. And you can do this any way you want to. You can say, I'm here to brush your teeth. Or if you can't remember what to say, you can read it right off the care plan. I am here to perform mouth care. You can read it right off the care plan. So, but we need to describe the skill. The whole purpose of describing the skill is to obtain permission or consent. What happens if the patient says no? Yeah, can we force them? No. Be very careful with that. There was just another case this weekend. CNA forced a patient to do something against their will. That's not our role. Be very, very careful here. Once we've got all of those steps done, we're going to close the privacy curtain. Is that clean? So what do we want to do after we do that? Wash your hands. And remember that you have to have clean hands before you touch the patient. That's a cardinal rule. So we'll wash our hands. After we've washed our hands, then we can go get our supplies. And don't touch resident until your hands are clean. All right. So now we have to think about gloves. Now that we've done our opening and we've read our care plan, we've done our opening, we know what we're doing. We have to decide if we need to wear gloves. Should we wear gloves for everything all the time so we don't have to think about it? Why? Yeah, cross-contamination. Absolutely. When you wear gloves without thinking about it, you're not thinking about it. And that's going to contribute to cross-contamination. Good morning. That's going to contribute to cross-contamination. So if we're not wearing gloves for everything, that means we've got to have rules about when we should be wearing gloves. So can somebody tell me one of the reasons that you will have to wear gloves for a skill? If you're going to touch... Okay, body fluids. Yeah, anything ooey and gooey that came out of somebody else. Absolutely. What else? If you're going to touch personal skin. Yeah, anything normally covered by a bathing suit. So this would be the breast area on females, the genital area on both sexes. So if you're going to be touching personal skin, you would need gloves. We also need to wear gloves if we're touching a different kind of skin. What? Anybody know the third one? A different kind of skin. Non-intact skin. So rashes, wounds, incisions, sores, any area where the skin is not intact. So if we're going to touch body fluids, personal skin, or non-intact skin, what do we need to wear? Gloves. So now that we know when to wear gloves, the first thing those gloves should touch is the patient, not everything else in the environment. If I were going to brush your teeth, okay, if I were going to brush your teeth, what kind of gloves do you want in your mouth? Gloves that have touched everything in the environment, or gloves that are fresh and new and haven't touched anything? Yeah, I want those, just for the record. Once we've worn gloves, we have to be careful about what we're touching in the environment so that we're not cross-contaminating throughout the environment. So if you've worn gloves and you've done your skills, should you touch that privacy curtain with those soiled gloves? Bed controls? Sheets? So we have to be careful not to further contaminate the patient's environment. And then we have to remove those gloves correctly. Now, to remove the gloves, we're going to pinch up at the cuff, pull that one off, and then go underneath the second one and pull that one off. That way, skin touches skin, but doesn't touch glove. All right. Sometimes we're going to need supplies, and those supplies need a place to be. What are we going to use to create a clean place for clean supplies? A barrier, that's right. You cannot put supplies directly on the overbed table. It's not clean. You can only touch supplies with what kind of hands? Clean hands, yeah. Don't let supplies touch your uniform. Very good. And we're going to go get that barrier first before we get the rest of our supplies, because you have to have two hands to spread that barrier out. And we can't hold anything up next to our uniform. So we go get our barrier first, put it on the table, go back and get the rest of your supplies. Sometimes we need a little extra privacy with certain skills. How do we know when we should use a privacy blanket? Anytime the patient is Undressed or uncovered. Yeah. Should I see knobby knees? No, I should not see knobby knees. So we're going to apply it to keep the patient warm. Remember that the environment is going to be a different temperature perception for them than us. We're up moving. They're not. We're fully dressed. They're not. So we're going to use that blanket to keep the patient not just covered, but also warm. So it's used for warmth and privacy. We'll use it anytime the patient is uncovered or undressed. We're going to put it on over the sheet and pull the sheet down underneath. That way the patient stays covered at all times. This is actually a pretty common mistake on the state exam. People will pull the sheet all the way down and then put the blanket over the patient. And that exposes that patient for that brief period. We don't want to do that. We want to put the blanket on over the sheet and pull that sheet down underneath so the patient is not exposed. We want to be very careful not to snap or shake the blanket when we put it on so that pathogens on the bed aren't aerosolized. They don't come up where we can breathe them in. So don't snap or shake the blanket. And then the last thing we do when we use a privacy blanket, the last thing we do before the closing is take that blanket away. The last thing. We don't want to touch that sheet that's going to go right up next to their face with soiled gloves. So if you've got gloves on, you have to wait until you've cleaned up your environment, put your basins away, put your towels and other linens and dirty linen, and then removed your gloves to put the blanket on. Does that make sense? It's the last thing we do before the closing. All right. Linen rules. A lot of these are repeats of things we've already gone over. So what kind or what can't touch your uniform? Yeah, anything. Linens, anything clean, linens specifically. What kind of hands do you need to get those linens? Clean hands. When we're working with linen, we want to be careful not to snap or shake those linens. We're going to skip a couple. We'll come back to those. And unused items must be, discarded or put in the hamper. We can't leave them for later. And then we went over the closing. Now, a good way of thinking about the closing is always leave your patient looking better than you found them. That's just a really good nursing principle. Always leave your patient looking better than you found them. So that means that we want to make sure the environment is clean. Yeah, pick up any trash. Straighten up their bedside table. Straighten up the sheets. Look around to see if there's anything that's out of place that needs to be addressed. Always leave your patient looking better than you found them. And we do that by ensuring a clean environment. What position does the bed height need to be in? Lowest. This isn't the head of the bed. I'm not talking about the head of the bed. Head of the bed can be however the patient wants or according to the care plan. The entire bed needs to be low. That way the floor is right where they expect it to be if they get out of bed. We want to ask about what word? Comfort. Yeah, they've got to hear that. Are you comfortable? But it's not just physical comfort. It's also emotional comfort. So we're going to address preferences. Now, this is where the head of the bed comes in. Or do you want a magazine or something like that? But we want to address their preferences. And I'm going to tell you, call lights are probably the biggest complaint that CNAs have. CNAs hate call lights because they always go off when you're in the middle of working with somebody else and they'll interrupt you. And every call light is a potential emergency. We got to stop what we're doing and go find out if it's an emergency. Call lights will interrupt your workflow faster than anything else. The way to reduce call lights is to take your time at the end of every skill and make sure that the patient has everything they need. So don't rush through this. When I leave a patient and I ask, is there anything else I can do for you while I'm here? I mean it. I'm not just saying it. I mean it because I'm trying to buy myself a block of at least 20 minutes that I can go work on somebody else uninterrupted. Okay, so this is your currency. This is how you're paying for that uninterrupted time you're trying to buy. So mean this. We have to make sure the patient is always covered by something. Now, if we dressed them, they're covered by clothes. Cool. If they're in bed, they've got to be covered by a sheet. If we're working with them and we have to take the sheet down, they've got to be covered by a privacy blanket, but they need to be covered, especially at the end of the skill. We're going to open that privacy curtain because we don't need it anymore. Our skill is over. And we're going to make sure the patient has their call light. Now, these steps, it doesn't matter what order you do them in. As long as they're all done, the order doesn't matter. Just get them all done. There's a lot of steps there. Get them all done. Once you've got all of these steps done, order doesn't matter, but once you've got all of the steps done, then you're going to go wash your hands. Now, what we're doing is getting the patient's cooties off of our hands so our hands are clean for the next patient. If you have to document, we got to touch a pen. We want to touch the pen with clean hands. So if you have to document, that would happen after you wash your hands. But our cardinal rule here is that we have to end skill with clean hands. And if I touch the pen, that means I have to do something else before I end the skill. What do I need to do? Wash your hands again. Very good. Don't return to the patient. If you return to the patient at all for anything, if you forgot to give them a call light and you've got to come back to the patient, make sure you wash your hands afterwards because we have to end skill with clean hands. Okay, good. Not too bad, right? All right, let's review some of the skills that we've learned. We learned pulse. So a pulse is a measurement of how many times the heart beat over 1 minute. When we're taking a pulse, and for pretty much every skill, really, we always want to support the arm. Remember, the elbow needs to be on the bed or on a table, not up in midair. When you hold an arm up in midair for a significant amount of time, it's going to increase the heart rate because our heart has to push blood against gravity. So we want to make sure that arm is supported. Pulses are always reported over 1 minute. Always reported over 1 minute. And how long we count is going to depend on the care plan. If the care plan tells us to count for 1 minute, how long are we counting? If the care plan doesn't specify, we can count for 15 seconds and then multiply that by 4 to get our minute reading. What is a normal pulse rate? 60 to 100. So anything outside of that range would need to be reported to the nurse. Very good. We're going to use the fingertips, not the flat areas of our finger. The fingertips are way more sensitive. You'll be able to pick up the pulse a whole lot easier if you're using your fingertips. Those of you who have long nails, whether it's acrylic or your natural nails or whatever, if you have long nails, it's hard to use your fingertips because those nails get in the way. So if you notice, I'm using my fingertips. If I've got really long nails, where are those nails going to bite into? Yeah. So keep that in mind when you're making your personal decisions about your personal grooming. Some places will not allow you to have acrylic nails. Some places are fine with acrylic nails. They just need to be a shorter length. Okay. That's a great interview question. What finger can we not use to take our pulse? Thumb, that's correct. Radial pulse is way up at the very top of the wrist, right below the thumb, where the thumb branches off, way up at the very top of the thumb side of the wrist. And where does our thumb need to go? Yeah, on the back of the hand under, and that holds consistent pressure. Remember, this is the most failed skill on the state exam. It's an easy skill. Why is it the most failed skill on the state exam? It's easy. Well, it's the most failed skill because most people don't count for 1 full minute. That means they're not following yeah, that's what they're grading you on, guys. And most people, if they don't put their thumb on the back side, will lose the count and then they'll make something up. It doesn't help. When we're counting with the evaluators, we have to say start and stop so that they start and stop with us. Remember, in Florida, we're counting with 2 evaluators, so you will need to count twice, once with each evaluator. And this is a documentation skill, so you must document at the end of the skill. Dressing a resident. Remember USA first, okay? When we're dressing a resident, we're going to ask them what they want to wear. Super important, guys. Super, super important. We need to know, what do you want to wear? If they suggest something that just simply does not go together, you can suggest an alternative. That's okay. But we're always going to honor their wishes. We lift from below with a flat palm, never from above. Always lift from below. And we support at the joints when we lift. This tells us how to dress and undress a patient that has a weak arm. We're going to USA first, undress strong arm first, and then we're going to dress the weak arm first. That allows the garment to just slide off that weak arm, no movement necessary, and slide back on the weak arm, no movement necessary. We're going to let that stronger arm do all the motion. We don't overextend or force movement. We adjust clothing for neatness. We dispose of items in the hamper. And we put the call light in which hand? The stronger hand. Very good. We also learn how to do range of motion. We're going to go over another range of motion today as well. Remember that CNAs do exercises to retain function. So we're just working with what they've already got. We're not trying to make it any better. So do we ever go past the point of pain? No. So we're watching for pain. We lift extremities from below with a flat palm. We've heard that before. We support near the joints. We've heard that before. We're going to move slowly and smoothly, return all the way to the start position. Flexion extension is up, down. Abduction, adduction is side to side. And rotation is around. How do we know which of those 3 exercises to do on the patient? The care plan. How do we know what body parts we're supposed to exercise? The care plan. Very good. So when we look at this, these are all the banners on the back wall. You've got this in your book as well. But when we look at this, you can see that we've already learned skill rules, opening, glove rules, barrier, privacy blanket, linen rules, and closing. That just leaves us 4 left. 4 principles left. And we're going to learn 2 of those today. Or 3. 2 or 3 today. So we're marching along. By the end of this week, you will know most of the principles involved. We'll do one more the following week, but you will know most of the principles involved. And then it's just a matter of reusing those principles over and over and over again to make skills. This is helpful for you to understand this concept, because when you go out there and you start working, oh, where'd I go? When you go out there, I guess I can go over here today. When you go out there and you start working in healthcare, where you work will dictate the skills that you're going to need to know. If you're working in a mother-baby unit, you're going to get really good at swaddling babies and helping moms with sitz baths. Be awesome at doing those things. But you're probably not going to be feeding a lot of patients, because on the mother-baby unit, moms generally feed themselves, right? So you're going to utilize a different skill set in every setting that you work in based on the patient population in that setting. Make sense? Okay. Make sense? All right. So what that means, though, is that if you go to work somewhere else, you're going to have to learn some new skills for that setting. And ideally, the new skills that you learn will incorporate principles that you've learned along the way, so you're not having to start from scratch. If you have to learn to do a washing skill, Well, all the washing rules are going to apply. If you have to learn to do something that has the patient uncovered or undressed, you know that a privacy blanket is going to apply. So these principles are going to be used out there as well when you start learning new skills based on where you're actively working. Good? Make sense? All right. So today we're going to get into hand and nail care. This is on page 116. I'll turn this camera a little bit. There we go. That's better. And to learn how to do this skill, hand and nail care, we have to learn a couple of new principles. So on page 116, when you're looking at this page, you can see all of the principles involved in this skill going down the side. We've got skill specific steps here. These are all the principles spelled out. This is your short version of the skill. I'll get a video for it. And along the bottom, you'll see test specific information. Somebody with your level of experience should be able to do this in 11 minutes or less. Guys, all we're doing is washing one hand, rinsing one hand, drying one hand, filing the nails of one hand, cleaning under the nails of one hand, and lotioning one hand. And they give you 11 minutes to get that done. Way more time than you need. Don't rush this skill. Okay. It's going to be done on a live testing student. That means one of you guys might be a patient for this skill. That person is going to be sitting in a chair, and charting is not required for this skill. So when you look at the principles involved, we know skill rules, opening, glove rules, barrier rules, linen rules, and the closing. But we don't know these two. So we need to learn washing rules and basin cleaning. And that's where we're going to start today's lecture, is with washing rules. We have 5 washing skills that we're going to learn to do in this course. 5 washing skills. So you're going to see this fairly often. This falls under ADLs, right? Because bathing is something you do for yourself every day. And in reality, you do all 5 of these together. You usually take a shower. You wash all of your parts all at one time. But patients don't always get everything washed all at one time based on their needs. Sometimes we have to do this in smaller chunks, like hand and nail care, foot care, partial bed bath, peri-care, catheter care. So even though you clean yourself top to bottom on a regular basis, in healthcare, we kind of break this up into smaller pieces because our patients may not have the stamina or the energy to do everything all at once. But there's another reason that we break this up into pieces, and that has to do with our patient being at risk. Okay, if our patients were able to take care of themselves, where would they be? Home, taking care of themselves, just like you. But our patients are not home, and they're not able to take care of themselves, so they are at risk. So that means we've got to pay a little bit closer attention to our patients' body parts than we do to our own, because they're at risk. Good? Good. All right, so in order to understand how the washing rules work, page 113, I have all of the notes for you. There's a couple things that we have to go through here, but all the notes are on page 113. So I want you to think about how you bathe. You get into the shower. You make sure the shower temperature is good for you. You get wet. You put soap on something. You soap yourself off. And then what's your next step? You rinse. Yeah. Would you ever soap yourself up and then get out of the shower without rinsing? Why? Yeah, you're soapy. That's just not done. We wouldn't do that. And yet, when we're bathing patients, it's really easy to forget to rinse. It is really, really easy. We have to understand that this is an essential step. Rinsing that soap off of the patient's skin is essential. We're going to get into that in a second. So if I need water for rinsing, I can't put soap in my basin. Whatever you wash, you rinse, and whatever you rinse, you dry. But since we have to rinse the soap off of the skin, we can't put soap in that water. Everybody got that? So basins are no soap zones. If you put soap in the water, you have nothing to rinse with. Now, some of you are thinking, well, just go get another basin. 2 basins, one for soap, one for rinse. Well, there's a couple problems with that. Number one, you might forget which is which. But number two, anybody ever been a patient at a hospital? Anybody ever been a patient? At the end of your stay, you get a wonderful gift. It's called a bill. And everything that was used on you during that hospital stay is on that bill. Every toothbrush they got for you, every basin they got for you, every aspirin that you took, everything used in your care is on that bill. Now, it may not be itemized. You might just get a bill with a total, but you can ask for an itemized bill. And you can go through and say, nope, 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 nope. I'll give you a good example of this. My mom was just in the hospital in ICU a couple of weeks ago. Well, I was doing my last class, actually. And it takes a while for all that billing to come through. She got a bill for a chest x-ray that she never got. No one ever did a chest x-ray on her at all. But she got a bill from the radiologist for reading a chest x-ray that was not taken. Because I told her, you need to ask for an itemized bill, and she did in all of the charges. So she contacted them and said, no, there was no chest x-ray. So we're waiting to hear the results of that, but there was no chest x-ray. Don't think that just because something is on a bill that it's correct. Now, when we think about basins, right, these basins are running somewhere between $30 and $40 a piece. I can go to the Dollar Tree and get one for $1.25, but at the hospital, we're going to charge you between 30 and 40 bucks for this thing. Do you want to pay $30 to $40 for something that you really didn't need to have? Your patient doesn't either. So don't just go grab supplies for them without thinking about it, because everything you grab is going to get charged to that patient. You actually have to scan it like a barcode scanner, and it will get charged to that patient. So be careful about what you choose to bill to somebody else without their consent. I look at this like going to a restaurant. You know, when I go to a restaurant, I look at a menu and I choose something based on what I can afford. Right? Can you imagine going to a restaurant and they don't give you a menu? They don't tell you prices. They sit you down, they feed you whatever they want to feed you, and at the end they give you a bill that they came up with. You have no idea what it's going to be, but if you can't pay it, we're going to take you to court. I probably wouldn't go back to that restaurant. Not a good way of doing business. But that is our healthcare system. Patients don't get a say in what's used on them, and then they get the bill at the end, and if they can't afford to pay the bill, they get taken to collections. One Wednesday or Thursday every month in this county is set aside at the courthouse for medical collections. This is real, people. Medical costs are the number one reason for bankruptcy. So we've got to be careful about what we choose to bill the patient for. Does that make sense? So since we don't add soap to the water in the basin, we don't, since we have to have water for rinsing, we don't add soap to the water in the basin. This allows us to wash and rinse with the same water. So a question a lot of people ask me is, okay, well, wait a minute. If I'm not putting soap in the water, where does the soap go? Well, it doesn't go directly on the patient's skin. Don't just squirt them with soap. What we're going to do is take the washcloth, wring it out really well. We don't like drippy wet washcloths anywhere. So we're going to wring that washcloth out really well so that it's damp. And then we're going to put the soap directly on the washcloth. And we'll use that on the patient. Any washcloth that has soap on it should not go back in your basin. Good? Make sense? All right. So we need to get water for bathing. We got to get water for bathing. We got to put water in that basin. But we have to think about when we're doing that and the infection control aspects of this. So remember that during your opening, hi, Ms. Jones, my name is Patty. I'm your CNA today. I'm here to do hand and nail care. Is that okay? I'm going to go close your curtain, wash my hands, and get my supplies. So I washed my hands, I got a barrier, I put it on the table, put all the supplies on the barrier, and now I am going to clean that, fill that basin up with clean water. So I'm taking that basin over to the sink. Is that sink faucet clean? But my hands are, because I washed them and all I've touched are clean supplies. So can my clean hands touch that faucet? No. So what could I use to turn the faucet on that would keep my hands clean? Paper towel. So when I'm getting water for bathing, I'm going to turn the faucet on with a paper towel because that faucet is dirty and my hands are clean. So we're going to use a paper towel to turn the water on. Now that water should feel warm, not hot, not cold, just warm. But there's a problem with this, and it's actually a pretty big problem that you probably don't know anything about. So we're going to take a little bit of time to explain this. One of the changes of aging that happens is that we lose a layer of subcutaneous fat underneath our skin. So younger people, if you look, you see skin. That's pretty much it. Skin. Have you ever looked at an old person's hand, the back of an old person's hand and arm? It doesn't look like that. There's big veins running right. It looks like somebody just draped skin over the veins. So that tells you that there's a difference between young people and older people. That layer of fat has disappeared. So the temperature that I perceive is going to be different from what the patient perceives. So we want that patient to check the water temperature as well. So I'm going to feel that water temperature with the inside of my wrist. It should feel warm, not hot, not cold, just warm. And I'm going to go over and ask my patient to check it as well. Would you like to check the water temperature? So this is a good visual that explains this. When we're younger, we've got big, thick layers of skin, fat, muscle, and the blood vessels are buried under all that. So they're not really visible. They're not really exposed. As we age, each one of those layers shrinks down. Well, what's running up inside each of those layers are nerves. As those layers shrink, those nerves are going to get more and more exposed. So as we get old, we get really, really thin layers and we can start to see the veins, but we also have more nerve exposure. So the way that I perceive temperature is going to be different than the way the patient perceives temperature. But let's talk about what that layer of fat actually does. So it's not just about water temperature. It's about all temperature. So that layer of fat actually acts as a wetsuit. And we need that. We need that layer of fat. Anybody know what normal body temperature is? Normal body temperature? 98.6 is what they consider normal, but we usually use a range, 97.6 to 99.6. Now, I'm just going to use 98 because it falls in the range and it's a really easy number to work with, right? I don't like decimals. Let's just choose 98. All right, so 98 degrees. If it were 98 degrees in this room right now, how would you describe 98 degrees? Hot. And yet our bodies run at night. Touch anybody next to you, that person is 98 degrees. 98 degrees. Now, room temperature is not, because we consider that hot. We aren't comfortable at 98 degrees. You guys got that? Okay. It's definitely not comfortable at 98 degrees. Okay. So what do I mean by this? Well, this temperature is so sensitive that if you go below 95 degrees, you're in hypothermia. If you go below 93 degrees, you are dead. Do you guys see how sensitive that is? We need to be in a very narrow range to be comfortable. If we go over 100 degrees, we call that a fever. So we have to live in this very narrow temperature range. Good? Makes sense? But there's a huge problem with that. Huge problem with that. And that's because room temperature always wins. Always. So in this room temperature is about 75 degrees. Okay? That's usually what we're comfortable with. Some of you like it a little cooler. Some of you are okay at 75. Some of you might want a little warmer. But in general, around 75 degrees is considered a comfortable temperature. We're going to use that because I like easy numbers. If we bake a pie and that pie comes out of the oven, how would you describe that pie? If it's just coming out of the oven, how do you describe it? Hot, right? It is well over 300 degrees. That pie is hot. You put it on top of the stove and leave it there for a couple hours. Does that pie stay hot? What happens? It cools down to room temperature. Room temperature always wins. Now, pie goes well with ice cream, so we're going to get some ice cream out of the freezer. When we get the ice cream out of the freezer, how would we describe that temperature? Cold, freezing. Put that ice cream on the counter, leave it there for a couple hours. When you come back, is that ice cream still going to be cold? No, it's going to be room temperature because room temperature always wins. Always. So if we have to stay around 98 degrees and room temperature always wins, there's got to be something here that keeps us warmer than room temperature. It is an active process. Because if you just put a body at room temperature is going to win. So we have to have an active process to make sure that our body temperature stays at around 98. And that is why we eat. When we eat, we burn calories. Have you ever heard that term? Burning calories. It's exactly what we do. We use food to generate heat. You thought you were eating for nutrition, right? We use food to generate body heat. Now, if we don't have a good system in place to help protect that body heat from radiating away, our furnace is going to have to burn a whole lot more body heat to keep us at 98 degrees. Does that make sense? So that is why you have a layer of fat along your entire body. It's to help keep your furnace from having to generate so much heat. It generates some heat, but your body fat keeps it in place, doesn't radiate off. That's a good thing. Keeps your body from having to work as hard. Make sense? Okay. But wait a minute. We just talked about that layer of fat getting smaller and smaller and smaller. So that means our older patients aren't going to have that layer of fat they need to keep their body heat consistent. That body heat is going to radiate away. So your patient will probably feel cold. Have you ever been around an older person that said they were cold? Or you walk into grandma's house and you're like, Grandma, let's turn on the AC. It's like 85 in here. Oh my gosh. And they're like, oh no, I'm good. I'm good. Or maybe you've heard an older person say, yeah, I'm from up north, but I just can't handle the temperatures up there anymore. It all has to do with this layer of fat being resorbed by the body. This is why Florida is the #1 retirement capital of the United States, because we have good warm weather here all year round. So the body doesn't have to work as hard. But that wetsuit, that layer of fat, doesn't just keep our body heat in, it also helps keep outside temperatures from affecting us as much. Okay. So if we have water that we feel is warm and we take it over to the patient and ask them to check it, and they put their hand in it and they go, oh no, that's way too hot. Remember that their nerves are way closer to the surface than yours, and they don't have that insulating layer. So if they say, oh no, that's too hot, believe them. I've seen lots and lots of CNAs that will argue with a patient. Oh no, it's fine. I just checked it. You're using this on their body. Get it comfortable for them, not you. Here's the other part of this when we're talking about bathing. Everybody has different bathing preferences. Me, I like water so hot, it strips paint. If steam isn't billowing, it's not hot enough for me. I like hot showers. And my husband, he likes cool showers. He works outside all day. He's had his fill of hot, thank you. He wants cool. Every single one of you has a bathing temperature preference, and it is not the same as the person sitting next to you. And yet, as CNAs, we tend to pretend everybody has the same bathing temperature preference that we do. They don't. We're there to help. Help isn't help if it doesn't help. Does that make sense? So when we get water, we check it, and then we ask our patient to check it as well. Probably the maddest I ever got at a CNA. Oh, I was really mad at this one. Oh my gosh. I still remember this. This was about 30 years ago, and I still remember this CNA. I was sitting at the nurse's station charting. I'd had a situation earlier in the shift, and it's a very long charting situation. I had to have a lot of brain concentration to write it all down. And I hear screaming coming from the shower room. I mean, terror screaming coming from the shower room. So I figured somebody fell. I went running down the hallway, open up the door, and steam just comes billowing out at me. I mean, I couldn't even see. My glasses were fogged up. And I walk in and had to take my glasses off just so I could see what's happening. And the patient is literally, she's sitting in a shower chair, literally fighting the CNA, kicking and hitting and fighting the CNA. I'm like, whoa, what's wrong? What's going on? I just turned the water off right away. The patient is red. And she said, it's too hot. It's too hot. It's too hot. And the CNA is like, it's fine. I checked it. The patient was fighting for her life. Is this the kind of care that CNA should be providing? Now, do you think that that patient is going to be agreeable to the next person that offers them a shower? No. So when your patients refuse to bathe, understand that there may have been a situation like this in their past. Because CNAs have to understand it is not about us. It's about the patient. That whole situation could have been solved very easily by the CNA asking the patient, is the water temperature okay? Patient says, no, it's too hot. And the CNA adjusts it. Easy. But when we start trampling patients' rights, we probably don't need to be in healthcare anymore. And that's what I explained to her. So the patient must check the water temperature. The state thinks that this is such an important checkpoint that if you fail to do this, it doesn't matter how good you did the rest of the skill, you will fail. This is a critical checkpoint. And I understand why. And I'm okay with that. Because your perception of temperature is going to be different than the patient's. Good? So whatever we wash, we rinse, and whatever we rinse, we dry, just like you do in the shower. But I want you to start thinking about bathing skills in this way. I want you to start when you're doing bathing skills, whatever I wash, I rinse. Whatever I rinse, I dry. This helps you keep track of your steps. Now, I know that sounds super simplistic. You're sitting there thinking, I would never forget to rinse a patient. But I've got over 5,000 graduates, guys. I have been doing this a long time. And I can tell you during the test, you're going to forget this step. So if you get in the habit of talking yourself through these 3 steps, you won't ever forget to do one of them. Everybody gets washing right. I mean, we got that one down. But you will forget to rinse. Some people forget to dry too. But be very, very careful. Talk yourself through this. Whatever I wash, I rinse. Whatever I rinse, I dry. I've had lots and lots of students that have told me, I heard your voice in the testing center. I heard you say this, and that's what kept me on track. If you don't rinse, this is what skin looks like, close up, microscope view, if you do not rinse. Do you see all that? That is dry skin because soap takes the moisture out of the skin. So if you look at this, those are skin openings, guys. Dry skin are cracks in the skin. What do we know about skin openings? They let pathogens in and out. We don't want soap to dry on the skin because we don't want to give these patients any more holes than they already have. So rinsing is super important here, guys. We want to change the water if it gets cold or soapy. Now, you've got 11 minutes to do this skill. Remember we talked about that a minute ago? You had 11 minutes to do this skill. It's an insanely long time. That water is going to cool, because remember, it just started out warm. It didn't start out hot. It just started out warm. So after 11 minutes, that water is going to be cold. So you want to do this a little bit quickly so your water doesn't get cold. But if it takes you some time, pay attention to how cold that water is. If it's cold, change it out. If it gets soapy, change it out because we need to be able to rinse. And then we want to be very careful when we're working with water that we don't get surrounding surfaces wet. This is why we use a barrier on the table. But you want to make sure that if something spills on that barrier, it doesn't drip onto the floor as well, which causes a slipping problem. Or if we're working in the bed, it doesn't get on the sheets because laying on wet sheets is very uncomfortable. But it also creates a warm, warm, dark, moist environment. And then if we put lotion on, we're going to warm the lotion up in our hands first, put it on, and then wipe off the excess because your skin can only absorb so much. Whatever's left on the surface of the skin will stay there. It's not going to get absorbed in. And if the patient goes to pick up a cup of hot coffee and they've got lotion on the surface of their skin, that's a safety issue. So we warm the lotion up first and then wipe off the excess every time we use lotion. So we've now learned washing rules. Anytime we have washing, we always have basin cleaning because the basin is what holds the water. So if we wash something, we're going to have to clean the item that held the water. But it only held water. We didn't put soapy washcloths back in it because that would have messed up our rinsing water. So it's just water. Your soapy washcloths went on the bedside, on the barrier, on the bedside table. It didn't go back in the basin. It's just water. So the way that we clean the basin is simply dump it out, rinse it, dry it, put it away. That's it. It's all we have to do for every basin that we clean. However, there are situations where we are going to have to disinfect the basin, not for the test, but in real life. If your patient is on chemotherapy, that basin needs to be disinfected. If your patient has HIV, that basin needs to be disinfected. If the patient has a known communicable disease, that basin needs to be disinfected. So how would we know when a basin needs to be disinfected? It would be on the care plan. So the process that I'm going to show you works very well for the test. We're simply going to rinse it, dry it, store it. That's it. But it allows for disinfection if that step is needed. Okay. So you'll see that we disinfect a lot of stuff. A lot of stuff was way more basin cleaning skills than there are washing skills. So we're going to clean a lot of basins. I've got information on this on page 91. And this is not what we call a sterile process. Disinfected is not the same as sterile. Sterile is a complete absence of pathogens. Absence of. Disinfected means that most of the pathogens have been eliminated. Remember we talked about hand sanitizer? We eliminated the pathogens, but where did they remain? On our hands. Disinfection doesn't remove pathogens. It just makes them inert. Does that make sense? Sterile is something completely different. Sterile is a complete absence of pathogens. So when we're disinfecting things, we're not making it sterile. We're just trying to get rid of the majority of them or make them inactive. Does that make sense? But for the most part, you don't need to disinfect. When you are in your home and you wash your hands in the sink, do you disinfect that sink every time you use it? No. Do other people in the house use the sink? Okay. When you brush your teeth, do you disinfect that sink every time you brush your teeth? Do other people use that sink? Sure. We don't, in a normal day-to-day routine, we don't disinfect things that we use on a regular basis. This is the same way. That basin is only used by that one patient. That's it. In your house, your sink is used by a lot of people, but that basin is only used by one person. So unless there is a need to disinfect, we just simply rinse it, dry it, and store it. Okay. So where you dump it is going to depend on what it is. And the way that we remember this is, where would it normally go? Well, if I'm working with saliva from mouth care, where do you normally brush your teeth? Sink. So where would the saliva go? If I'm working with urine, where do you normally urinate? Yeah. Not talking about 2 a.m. at the club and all the bathrooms are full. I'm not talking about that. All right. So if we normally dump urine in the toilet, that's where it's going to go. You have to think anything bathing usually goes in the sink. Anything elimination related will go in the toilet. So where does it normally go? Dump it there. Once you've dumped it, whatever it is and wherever it went, once you've dumped it, then we're going to rinse the basin. Now, depending on the skill, you might or might not have gloves on, depending on the skill. And it's okay to keep your gloves on while you're cleaning your basin. In fact, you should keep your gloves on while you're cleaning your basin because that basin probably had some sort of body fluid in it. So we're going to leave our gloves on. Some skills, you won't have gloves on to do the skill. And in that case, you just clean the basin with your bare hands because you're going to wash your hands at the end. But we're going to rinse our basin. Now, once we rinse that basin, remember, they're only used by that one patient. They only need to be rinsed after each skill is done. But if we do need to disinfect, so we rinsed our basin and we dump that rinse water wherever it normally goes, wherever the item the basin was holding went. If we need to disinfect, we're going to do it at a very specific time in this process. So we rinse the basin and we had our gloves on or our dirty hands, either way, holding that basin when we rinsed it. I can't disinfect it while I'm holding it with dirty gloves. Do you guys understand that? You can't disinfect it. You can't spray this basin while holding it. We have to put it down to disinfect it. So we're going to put it down in the bottom of the sink and we're going to spray it with disinfectant spray. But now we have to pick it up. Should we pick it up with our dirty gloves or dirty hands? So we're going to use a paper towel to pick it up so that we aren't touching it with soiled hands or soiled gloves, which would recontaminate it. So we would use a paper towel to pick it up. So the way this works, we're going to dump our basin, rinse it out, dump that, set it down. Spray it if needed. We don't spray it for the test. Pick it up with a paper towel. And then we're going to dry the inside. And you want to get it dry because we're going to put it away in a dark drawer. If it's still wet, we now have warm, dark, moist. So make sure you dry it. So we're going to dry the inside real well. We're then going to dry the outside with a different paper towel real well. And then we're going to get one to get all of our supplies, put it in the basin and put that in the drawer. You do not want to touch the front of that drawer with your dirty hands or dirty gloves. And that's why you need a paper towel. Now you're going to see this for this skill that we're going to do. You're going to see this whole process. Don't panic if you don't get it right away. Remember, we've got a lot of basin cleaning coming up. You're going to see this over and over and over again. It'll start to click. But we dump it, rinse it, set it down, spray it. Paper towel to pick it up. Paper towel to dry the inside. Different paper towel to dry the outside. And then one for the supplies in the drawer. Good. So everything is cleaned the same way. It doesn't matter whether it's a bath basin, emesis basin, bedpan, graduate container. It's all cleaned the same way. So this is basin cleaning. You've got this in your book. So now let's talk about hand and nail care. So when we are washing one hand, and our care plan is going to tell us to perform hand and nail care to one hand. We're going to soak the hand in water. We're going to put it on a towel. So we're going to soak it. Remember, we've done our whole opening. Washing rules applied. So we ask them to check the water temperature and all that. Once their hand is in the basin soaking, we're going to support it, take it out and put it on a towel. Don't just lay it on the hard surface. Lay it on a towel so it's softer. And we're going to wash, rinse, and dry. Once we're done with that, we're going to clean under the nails with the beveled end of the orange stick. And when you do that, you're going to put the beveled end of an orange stick underneath. Do I have one in here? Underneath the edge of the nail. This is an orange stick. We use orange sticks because they don't splinter, which is important. We're going to use the beveled edge of the orange stick. We put it underneath the edge of the nail, circle it around. But now I've got debris from this nail on this stick. Should I put it under this nail? I'm going to wipe it off on the towel before I go to this one. I'm going to clean under this one, wipe that one off, clean under this one, wipe that one off, clean under this one, wipe that one off, clean under this one. That's how an orange stick works. You guys can, most of you should be familiar with that. Don't use the pointed end. Okay. Oops. Okay. So we clean under the nails with the orange stick. We're going to file the nails in one direction only. When you're filing nails, this is something else that changes as we age. So as we age, the nails themselves will get very brittle and they'll start to get lines on them and they'll get ridges. Now, this is just part of the aging process. Your nails become a little more brittle. Well, one of the things that happens with older people's nails is that the nail itself can split right down the middle. I've actually got a nail here that's doing that. It's splitting right down the middle. So if you take an emery board and you go back and forth really rapidly across the surface of the nail, which is what you guys do when you're filing your nails, if you do that, what that does is it pulls and pushes that nail as you file. So you're pushing and pulling and pushing and pulling. And the center of the nail doesn't move. So you're pushing and pulling, and that center is staying steady. So if that nail is going to split, it will right down the middle. And when I mean down the middle, I mean all the way down the middle. That is horribly painful for your patient. So we don't, with an emery board, we don't go back and forth. We go in one direction only toward the center. And then we just take that point off. One direction, not back and forth. Make sense? Okay. One direction. All right. Once we've washed, rinsed, and dried the hand, we cleaned under the nails, we filed the rough edges, then we're going to lotion. So we're going to put some lotion on our hands, warm it up, and we're going to apply that to all surfaces of the hand and then wipe off that excess so that the hand is dry after the lotion is applied. Lotion is always applied last. Otherwise, you're going to get too much gunk under the fingernails. You're not going to be able to clean it effectively. And it can actually interfere with the filing process. CNAs do not trim nails. Fingernail clippers are advanced pieces of medical machinery we're not allowed to touch. CNAs do not clip fingernails. If you keep fingernails filed on a regular basis, you never have to trim them. Just keep them filed. And as we age, everything slows down. So nail growth slows significantly. So does hair growth. So your patients usually will do hand and nail care once a week, and that will keep the patient's nails at a manageable level so we never have to trim them. Good? Questions on this? No? I'm going to show you this video. It has really good close-ups. Good morning, guys.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm doing great. How about you?
Wonderful. I need to do hand and nail care on one hand. Is that okay?
Yes.
I'm going to close your curtain for privacy. Let me go wash my hands, and then I'll gather my supplies.
Okay.
Okay, we're going to start with the barrier. So I'll place the barrier on the table, and that will give me a place to set your clean supplies. And then I'm going to gather a basin, soap, and lotion. An orange stick and emery board. Two washcloths and a towel. I'm going to go get some water in the basin.
Okay.
Okay, Mr. Jones, would you like to check the water temperature, make
Yes,
sure it's
please.
okay?
It's
Is
great.
it good?
Yes.
Okay, you can submerge your hand in there if you'd like,
Okay.
and I'll bring that tray a little bit closer to you.
Thank you.
Is that comfortable?
Yeah.
I'm going to place the washcloths in here, and we'll wet one of the washcloths and use it to get your hand wet. Now I'm going to place your hand over here on the towel. Apply soap to the washcloth. And now I'm going to wash all surfaces of your hand, including in between the fingers, in this area between the thumb and the forefinger. We're going to turn your hand over now and wash the palm of your hand. Now we're going to place your hand back in the basin to rinse. Okay, I'm going to bring your hand over here to dry. I'm going to dry between the fingers. And then I'm going to turn your hand over and dry the palm of the hand as well. Okay. Now we'll take the orange stick and I'm going to clean under each nail. Just cleaning the edge. Does that hurt?
No.
Very good. We'll wipe the orange stick on the towel in between each finger. And now I'm going to file any rough edges. So I'll file from the outer edge to the middle, checking each nail for any rough edges. And now we can apply lotion. So I'll get a little lotion, warm it up in my hands, and apply it to all surfaces of your hand. Does that feel good?
Yes.
Very good. Okay. Now we'll wipe off the lotion. Okay. How's that?
Great.
Wonderful. I'm going to place my soiled linens in dirty linen container and then clean up my workspace. I'll be right back.
Okay.
Okay, on the way, we'll pick up the soap and the lotion and place them in the basin. We'll use the paper towel to open the drawer, place the basin in. These items will get thrown away. Okay, Mr. Jones, are you comfortable?
Yes, ma'am.
Can I offer you a magazine?
No, ma'am.
Is there anything else I can get for you while I'm here?
No, thank you.
Okay, your call light is right there. Please use it to call me if you have a need. I'm going to open your curtain and wash my hands. After washing my hands, I'll review the steps of my skill, make any corrections, and then tell the evaluator my skill is done. All right, any questions on hand and nail care? Pretty easy. Pretty easy. As far as the washing skills go, that's the one I would want. It's foot care, just like hand and nail care, just lower. I don't get on the floor very well anymore, so I want hand and nail care. Partial bed bath, longest skill that we have, 19 minutes. Pericare, catheter care, those are easy too, but you'll have an emotional difficulty with where you're washing. So out of the washing skills, that's the easiest. But all the other washing skills are done the same way. Whatever we wash, we rinse. Whatever we rinse, we dry. We check the water, they check the water. Don't get your surface wet. Change the water if it gets cold or soapy. But we know all these steps, so they become pretty easy to learn. All right, now we're going to go on to page 141, changing an occupied bed. After we get done with this skill, we'll take our break. We are going to learn blood pressure a little later today. All right, make an occupied bed. So if you look down the side here, you can see that this skill is made up of skill rules, the opening, glove rules, barrier rules, privacy blanket, linen rules, scoot and roll, which we don't know yet, and the closing. They're all spelled out for you over here. This is skill-specific information. And then over here are kind of your short form of the skill. I have a video for this. Along the bottom, you can see your test information. Somebody with your level of experience should be able to do the skill in 14 minutes or less. We're going to talk about that in just a second. Live testing student, that means somebody will be in the bed for you to do this skill. You might be the body in the bed for this skill. That person's going to be in bed. Charting is not required. 14 minutes. That's what they give you to make an occupied bed. I can do it a whole lot faster than that, but I've got a lot of experience. But I can make an unoccupied bed way quicker. In about 2 minutes, I can make an unoccupied bed. I can change that entire bed, the whole thing, in about 2 minutes if nobody's in it. I've timed myself, I know. But you put a body in the bed, and now it's going to take me about 6. Okay. I would much rather spend 2 minutes making a bed than 6 minutes. It's also easier on the patient. So anytime I walk by a patient's room and there's nobody in the bed, my mind immediately thinks, does that bed need to be changed? Do those linens need to be changed? Because if the patient's out of bed at a test or an activity or whatever, that is an ideal time to change that bed. So if you walk by an empty bed, you should automatically think, do those sheets need to be changed? Do you know how the bed feels when you get in and you just change the sheets and they're all nice and fresh and clean? You know that feeling? It makes you feel good, right? Well, patients are the same way. They've got so many other things going wrong that if we can give them some clean sheets, they'll feel better. At least it's something to help them. So if you walk by an empty bed, you should automatically wonder, should I change those sheets? But sometimes we have situations where the patient can't get out of bed. They don't go to tests. They don't go to activities. They're in bed all the time. And we have to change the sheets around them. As sheets are going to get changed, generally speaking, every 3 days in a healthcare setting, or if they're soiled. Anybody ever have a fever? What does a fever make you do? sweat. So if you have somebody who is running a fever, and we would know that because we take vital signs, do you think that you might want to change those sheets a little more often? So the frequency that you change sheets is going to be influenced by what is going on with your patient. Good? Questions? Neighbor of mine went to the hospital years and years ago. He was in that bed for 9 days. Nobody ever changed his sheets. How do you think those sheets felt to him after 9 days? Pretty gross. All right, so let's learn how to change sheets. In order to do this, we know all of these principles except scoot and roll. We know linen rules. We went through all of this, but there are two things that we skipped last week. 2 points to linen rules, and we want to go over those. So we want to fill this in. So one of them is clean rolls toward you, dirty rolls away. And the other one is don't let clean or dirty linens touch the floor. So let's talk about the first one. Clean rolls toward you, dirty rolls away. Okay. Get my visual aids here for you. All right, so let's say that we have a bed with a sheet on it. So this is my bed with a sheet on it. And this is my patient laying in bed. Everybody see that? I got a bottom sheet and a patient laying on the bottom sheet. So if I need to change that bottom sheet, I'm going to use clean rolls toward me, dirty rolls away. And let me show you what this does. So if I take this dirty bottom sheet and I roll it away from me, I roll it away. What's facing up here, the part that I'm touching, is the underside of the sheet, the part that wasn't directly touching the patient. So I'm going to roll that up, and I'm going to take my clean sheet and clean rolls toward me. So when I do that, the underside of the sheet is what's facing up. And I'm going to tuck the clean sheet underneath the dirty, but the only part of those sheets that are touching are the undersides of the sheet. This helps minimize what we call gross pathogen transfer. It's not going to eliminate all pathogen transfer because who's still in the bed? The patient. Don't get wrapped up in, well, the dirty sheet touched the clean one. Yeah, the patient's still in the bed. It doesn't matter. Okay, we're trying to change the sheets, not do a sterile process here. Make sense? Good. So clean rolls toward me, dirty rolls away. And if you do that, the undersides of the sheet are what's going to touch. But when you're changing the sheets, let's look at this guy again, right? So I've got a patient laying on a sheet. Look how much room that patient is taking up on my bed. Quite a bit. If I turn the patient on their side, how much room do they take up? A lot less. So if you turn a patient on their side, it makes it easier to change the sheet because less of them is holding that sheet down. Good? Questions? All right. Okay, Faith has a question, but it doesn't have anything to do with the skills that we're doing today. Faith says, just a question regarding feeding. Do you have to wear gloves when you feed? Faith, I'm not going to get into that right now, but our glove rules are, if you're going to touch body fluids, personal skin, or non-intact skin, we need gloves. When we're feeding somebody, we're out the other end of the spoon, as long as they aren't actively drooling or something like that. We're not touching any personal skin, body fluids, or non-intact skin, so gloves are not indicated. All right. We don't want anything to touch the floor. Clean, dirty, doesn't matter. Nothing touches the floor. Now, this is a problem though. When you change your sheets at home, you probably take them off the bed and throw them right on the floor. That's what we're used to. We take sheets off the bed, throw them on the floor. We won't think twice about this. It's just our normal routine. The problem is that we don't want to transfer pathogens onto the floor that you are going to walk through and then take all over that facility on your shoes and home with you at the end of the day. The roommate has to get out of bed and walk to the bathroom. We don't want them walking through pathogens. Nothing goes on the floor in a clinical setting. So what we do at home is different from what we're going to do in a clinical setting. Make sense? Nothing goes on the floor. Not clean, not dirty, nothing. So when you're doing this skill, for the test, they're going to make it super easy. They're going to have a hamper like this, very near the bed, or they'll have a laundry basket at the end of the bed. They're going to make it very easy for you. Everything is right there. So you can put your dirty linens in the hamper right away, no problem. The problem is that in a clinical setting, we don't keep hampers in the room. We don't keep dirty items in the patient's room. We don't want dirty in a clean environment. So these hampers are usually out in the hallway, or they could be in a special room called a soiled utility room. This is where we keep all dirty stuff. We try to keep it all in one place so it's not contaminating the environment. So if we don't have a hamper in the room, or at the end of the bed, or within easy reach, what do we do with these sheets if we can't put them on the floor? So in a clinical setting, we're usually going to use a soiled linen bag or a chucks on the floor. Either one of these is usually used. So if you put a chucks on the floor and put the linens on the chucks, we're okay. If you have a soiled linen bag and you put them directly in the soiled linen bag, that's good. Just no linens directly on the floor. Like I said, for the test, you'll have a hamper right beside the bed or at the foot of the bed to make it really easy for us. Everything dirty goes into soiled utility. Those bags, let me tell you about those soiled linen bags. They're super light blue. The bags themselves are very, very thin, and they're a really light blue. They're going to be stamped with soiled linen on them. Do you guys know Tide Pods or, the Game Flings or all those, laundry pods, right? These were the original. We've been using these for like decades. These were the original Tide Pods. These bags are water soluble. So when you put linens in that bag, that whole bag is going in the washer. It dissolves, it becomes the soap, the whole thing goes in the washer. So nobody is taking those linens out and shaking them out to make sure there's nothing in the linens. When you put linens in a bag, everything that's in that bag is going into the washer. So if the patient's dentures are in the bag, where are the dentures going? If the patient's hearing aids are in the bag, where are they going? Yeah. If the patient's cell phone is in the bag. So when we are collecting linens, when we're changing sheets, we have to be looking for things that should not go in the washer. So things like hearing aids or pens. Pens are a big one. Cell phone chargers, all kinds of things. Eyeglasses. If we ruin the patient's belongings, the facility has to reimburse the patient. Those things can get expensive. So be really, really careful to look when you're changing those out. With linens, we use it or we lose it. We already learned this earlier. So if you take too many linens and you don't use everything you take, don't leave it in the room. If it's out of our sight, it's not considered clean. You have to put it into dirty linen. So this is the last thing that we have to learn in order to learn how to make an occupied bed. So this is a new principle for us. It's called scoot and roll. And this is in your book. I don't know what page this is on. Page 120. This is scoot and roll. That online course that I enrolled you guys all in, the online course for your CNA, I'm writing graded. They all have questions in every lesson at the end of the lesson that are kind of like knowledge check questions, just to make sure you got the concept. But I'm writing, have been for the last couple weeks, graded questions for every single lesson. This is something that a lot of the instructors have been asking for. So I have been stuck in question something for a very long time. And I spent all day yesterday writing questions. And this was one of the lessons that I was working on yesterday, scoot and roll. This is one of the most important principles that you have to learn. One of the most important principles, because this has a direct effect on our patient. Direct effect. In order to understand what I'm about to tell you, we need to understand that side rails are considered a restraint. You cannot use side rails without a doctor's order. Even if your patient asks you for them, even if you think the patient is safer with them, you do not get to make that call. Ever. Ever. And that's because side rails restrict a patient's freedom of movement. You guys are used to getting up and moving around any way you want to. You're adults. If you want to get up at 2 a.m. and go to the refrigerator and grab a midnight snack, there's nobody standing there telling you you're not allowed. You're an adult. You get to make adult decisions for yourself. At what age are you willing to give that up? Never. Never. Your patients don't want to either. So when we put a patient in a bed and put the side rails up, we are telling them don't get out of bed. We are interfering with their right to move about as they wish. And if that's not a right you're willing to give up, don't expect your patients to. What ends up happening here is this patient, they're unsafe on their feet. You put them in bed, put the side rails up, gave them a call light, said, call me if you need to get out of bed. We want to make sure you're safe. And the patient eventually has to pee, and they hit the call light, and they wait, and they wait, and they wait. In the meantime, we got IVs pumping fluids into them, and they wait, and nobody comes. Now, at some point, they're going to be faced with a choice. They can either wet themselves in the bed, or they can try to get up over those rails and get themselves to the bathroom. Do you know what most people will end up doing? They're going to get themselves to the bathroom. Now, did we truly make it safer for them? No, we did not. We cannot use side rails in the name of safety. Side rails do not keep people safe. Now, some of you are thinking, yeah, but what if the patient's like really weak? You know, if they're a fall risk, we don't want them up wandering around because if they fall, I could get in trouble, right? So who are we thinking about here? Yeah, we're thinking about us, not the patient. So let's talk about that for a second. Let's say we got a really weak patient. We don't want them up walking around because we don't want them to fall. And our heart's in the right place. We're thinking about the patient here. So healthcare is supposed to help, right? That's what we're there for. We're supposed to help. If you put a patient in a bed for several days and they do not get up and move, is that going to increase their strength, balance, or mobility? What do you think? No, it's not. When you trap a patient in bed, it doesn't increase anything. It actually decreases it. So when we put a patient in bed in the name of safety, we actually have restricted their movement, which will cause a decline in their overall health and wellness. You guys see that? Side rails cannot be used without a doctor's order because sometimes we get our brains a little mixed up on this. We start thinking about us, not the patient. Make sense? We're going to talk a little bit more about this in an upcoming lesson. But you do need to know that side rails are a restraint. The thing is, you don't need side rails to keep your patient safe in bed. Side rails actually increase the risk of injury because if the patient tries to get out of a bed with side rails, especially like these side rails that I'm going to show you in a minute, they'll get trapped in between, and it's really easy for them to. Side rails kill about 200 people a year. 200 people a year. That's horrible. But it's really easy to get an entrapment situation. So if we use side rails, we have to check on it's a restraint. You got to check on those patients every 15 minutes. So there's a difference between side rails and positioning rails, and that's what you see here. These are called half rails or positioning rails. These are not side rails. They don't prevent the patient from getting out of bed. This patient can swing their legs out and get out of bed just fine, but they've got these little handholds that help the patient turn over or pull themselves up or reposition. Same thing with these middle bars. These are called half rails, not side rails. So a little bit different. So we have to understand our terminology here. Let me turn this around so you can see this bed. Okay. So we've got a patient laying in bed. If this rail is up, that is not a side rail. These are allowed to be up, no problem, because it allows the patient to have freedom of movement in the bed. Now, if I come along and put this side rail up, if the patient tries to get out of bed for whatever reason, they have to go through this little gap, or they got to scoot all the way to the end to go through that gap. Either way, I've increased their risk of injury. Did this make it safer? In most settings, you won't even have these on the bed. They take them off. We don't trust you with them. Because CNAs will put side rails up all day long and say, well, the patient asked for it. They requested them. That's not our role. So we don't even have these on the bed. If you get an order for side rails, usually maintenance has to come put them on. Questions on that? Questions? Okay. So top rails are positioning rails. Okay. So you will not have side rails in all settings. Yes, Faith, that's correct. Side rails have to be in the care plan and ordered by a doctor, correct. So you won't have side rails in all settings. In fact, most assisted living facilities are a no restraint facility. They're not allowed by law to have them. Nursing homes are mostly a no restraint facility, but there are some exceptions. And that's when maintenance usually has to come put them on. Hospitals, they're becoming no restraint facilities. And it's interesting because hospitals are solving this in a little bit different way. And I love what they're doing. I really do. Hospitals now, instead of using restraints or side rails, which we know don't really keep the patient safe, they hire what we call patient safety attendants or sitters. And your job is to sit at the side of the bed. And whenever the patient tries to get up, you find out what they need and you get it for them. Or you notify the staff that this patient wants to get up. So you are there to make sure that the patient doesn't fall, doesn't get up on their own. And all of you are eligible for those positions right now. So you can look up at our local hospitals, patient safety attendant or sitters. And those are positions that you're available or qualified for. So side rails make patients weaker. They don't improve anything. They cannot be used routinely. They have to have a doctor's order, and they're considered a restraint. To remain safe, though, we don't need side rails. We just keep the patient in the middle of the bed. That's it. As long as that patient's in the middle of the bed, what we call the safe zone, you don't need side rails. And that's because you don't need side rails. You don't. So let me show you what I mean by this. Let me get a volunteer. Somebody come over here and lay in this bed for me. Thank you. Okay, if you can just lay on your back in the bed. Okay. So where did she position herself? Yeah, in the middle. I didn't ask her to do that. She knows she's not going to be there very long, but she still put herself. Why didn't she go right on the edge? Would have made more sense. She knows she's not going to be in bed long. Why didn't she put herself right on the edge? Because her brain said that's not safe. Her brain made her get in the middle. You weren't aware of that, were you? Okay. You aren't aware of this. This is something that you do automatically. So can I get you to roll so that you're facing that wall for me? Okay, where is she? Still in the middle of the bed. She did not roll. I asked her to roll on her side so that she was facing the wall. She did not roll. She shifted. She moved her bottom backwards so that after the roll, she was in the middle of the bed. I didn't ask you to do that, did I? But you did it automatically. Now, why did she do it automatically? Because her brain knows that if she rolled, she would be too close to the edge, and that is unsafe. Her brain would not let her do that, so she shifted instead. Thank you very much. Great. So, your brain does this without you being aware of it. Your patients also have brains. And those brains will also do this without you or without them being aware of it. Patients will keep themselves safe in the middle of the bed whenever possible. It's only when we get involved that goes out the window. So when we get involved, we need to make sure that we understand this concept so that we can keep our patients safely in the middle of the bed at all times. Okay, good. If you just roll a patient, they're going to be on the edge of the bed. That is not safe. So instead of just rolling the patient, we're going to ask them to scoot toward us first. Then we can roll them, and they'll end up in the middle of the bed. Okay, this is called scoot and roll. Remember, you will not have side rails in all settings. So we'll have the patient scoot toward us, roll onto their side, and that keeps them in the middle of the bed. Now, patients always have to turn away from you. Never turn a patient towards you, and there's two reasons for that. The first is weight distribution. We'll come back here. First is weight distribution. When you are on your side, most of your weight is along your back. The back of your head, your shoulders, your butt, most of your weight is back here. Gravity always pulls the patient back onto their back. We know this. So if you roll a patient towards you, all of their weight is way far away from you. And if gravity tries to pull them onto their back, you are not in a position to stop that. You're on the wrong side of the patient. And that's how falls happen and injuries happen. But there's another reason that you never turn a patient towards you. And that's because it puts the patient at eye level with your crotch. And that can be construed as sexual harassment, no matter what your sex is. So you never turn a patient toward you. It's always away from you. So scoot toward me and roll away. So when we're talking about the bed, there's a couple different positions here. We have head of the bed, foot of the bed, entire bed high, and entire bed low. And we've got a bed controller that controls all of these things. Head of the bed just moves the top of the bed. That is patient preference at the end of the skill, unless otherwise specified in the care plan. Foot of the bed, we don't really mess with as CNAs. Entire bed high, we're allowed to do. But at the end of the skill, we have to make sure the entire bed is low. Now, I bring this up because we are going to be making a bed. And if you are at all taller than me, and most people are, that means you're going to be bending a lot for this skill. And this position is bad on your back. So you can raise the entire bed up to a comfortable working height for this skill for the test. No problem. Knock yourself out. If it makes you more comfortable, raise the entire bed up to make it comfortable. But at the end of the skill, you have to remember to put that entire bed back in the low position at the end of the skill. Otherwise, it doesn't matter what a great bed you made, you failed. We want to keep the patient from lying on a bare mattress, and this is that clean rolls toward me, dirty rolls away. That means that the mattress is always covered by something, whether it's the clean sheet that we're putting on or the dirty sheet that we're taking off. We don't have the patient lying on a bare mattress. So if you look on page 142, at the top, we have the care plan. It says change the top sheet, bottom sheet, and pillowcase while the resident remains in bed. Resident can roll and move as directed, but cannot get out of bed. A bedspread, blanket, draw sheet, or underpad is not required for this skill. So top sheet, bottom sheet, pillowcase, all we're doing. That's all we're doing. Your patient's going to be uncovered. So what do we need to use? You've got supplies. Top sheet, bottom sheet, pillowcase. Where are you going to put them? On a barrier. You want to make sure those supplies don't touch your uniform. No linens can touch the floor. If we're going to turn a patient, we have to scoot them toward us first. So you see how all of these principles are going to be combined to make up this skill. Okay. All of your supplies are located at the bottom here. Shows you what you need for this skill. All right, so let me show you this video. Oh, this is a great question, Faith. Does bed making require gloves? Great question. Let's go over that real quick. We evaluate gloves for every skill. We figure out if we need gloves for every skill that we do. Now, the problem is that every patient is going to be different. I can't tell you you will always need gloves for every patient, period, because every patient's a little different. So in that bed over there is our patient. That patient is continent, holding on to all of their own body fluids, fully dressed, and no incisions, sores, or other wounds anywhere. Do I need gloves to change those sheets? I'm not going to touch body fluids, personal skin, or non-intact skin, so I don't need gloves. You could if you wanted to, but now you've just added on a couple of extra checkpoints to your test. Because if you're wearing gloves, now we have to worry about what else we're touching with those gloves. And we also have to remove our gloves correctly. So you're now increasing the difficulty level of your test. The other problem with wearing gloves when you don't need to is environmental. I'm not a tree hugger. I'm not. I don't recycle. I drive a gas guzzler because I like speed. I'm not an environmentalist. But this does kind of get under my skin a little bit. What do you think happens to gloves after you use them? What's that? They get dirty. Where do they go? Trash. Where does that trash go? Okay. So every pair of gloves that we wear ends up in a landfill somewhere. Okay. Problem is that latex gloves are biodegradable, but it takes like decades for those gloves to break down. Decades. The other types of gloves, vinyl and nitrile gloves, which are way more popular, they don't ever break down. That means that every pair of gloves that are worn today will be on this planet 100,000 years from now. Now, we used to, back in the 80s, burn everything. Every hospital had an incinerator. We would just burn it all. And that worked really well until we realized that we actually created a hole in our ozone layer from all of the smoke and, chemicals that we put up in the atmosphere. We decided that wasn't a good idea, so we don't do that anymore. So the gloves and other medical waste just kind of built up for a long time. Someone came along and said, you know what? We got all this medical waste. We need to have somewhere to put it. We got a big ocean out there we're not using. So we put them in big metal drums, poked holes in the top of the metal drums, took them out to the middle of the Pacific, put them in the water. They filled up, sunk to the bottom. Well, it's, thousands of feet down. We'll never even know. Except now, the fish that they're pulling out of the northern Pacific have high levels of latex and we can't eat them. We poisoned our own food supply. So we decided that's not a good idea. So we can't burn it and we can't drown it. So at this point, we have no answer for what we're going to do with all of these gloves. And in America, just healthcare. Just America, just healthcare. Not talking about food service or housekeeping or industrial, just America, just healthcare. Just gloves. We fill a football stadium 35 feet deep every day with gloves. So it doesn't take me long to realize that this isn't going to be my problem. I'm out of here in like 30 years. Not going to be my problem. It will be my granddaughter's problem. Because you can't keep up that sustained level of medical waste with no answer to the problem. So, should you wear gloves when you don't need them? Probably not. Probably not. Then you've got the whole cost factor. Those gloves cost money. And if you're wearing gloves unnecessarily, your facility has to pay for that. And when you're wondering why you only got a 1% raise, it very well may be that they can't afford to give you any more because their supply costs are so high. So we have to think about the long-term implications of the decisions that we make. So Faith, I hope that helped you. All right, in the case of if we're changing sheets and there's body fluid, should we wear gloves? Sure, absolutely. If we're changing sheets and the patient has a big old incision on their hip, should we wear gloves? Absolutely. But if we don't need them, then don't wear them. Like I said, I'll be out of here in 30 years. Not my problem. This is your problem. All right, so here are our step-by-step instructions on how to perform this skill. Oops. Let me go ahead and show you this one. This is actually my favorite skill to do. It's like a Houdini trick. Like, patients just laying there and the sheets get changed around them. It's actually a really cool skill to know. I used this with my kids when they were little, when they're sick or too tired and something happened and they spilled their milk or juice or whatever and I need to change sheets. I used this a lot when I was a mom. This is a great skill to know. It's not very hard either.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I need to change your sheets. Is that okay?
Yes.
I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back.
Okay.
We'll start out with the barrier. I'm going to get a top sheet, a bottom sheet, and a pillowcase, and a privacy blanket. Okay, Mr. Jones, I'm going to place this blanket over you. This will help protect your privacy and keep you warm while we do this scale, okay?
Okay.
Okay, I'm going to spread this out. Can you hold that blanket in place?
Yes.
And I'm going to remove the sheet from the bed. We'll place the sheet in dirty linen. Mr. Jones, can I get you to scoot toward me, please? Thank you. And can you roll so that you're on your side facing in that direction? Thank you. I'll remove the two corners of the sheet from this side of the bed. And I'm going to roll the soiled sheet in toward the patient, tightly. I'm going to tuck it up underneath the patient all along the length of his body. Now I'll take the clean sheet, unfold it, spread it out on the mattress, and attach the corners. Now I'll roll the clean sheet toward me. We'll roll it so that it's tight with no wrinkles as we tuck it under the soiled sheet. Okay, Mr. Jones, come on back onto your back, and I need you to scoot to the center of the bed, please. Thank you. Can you scoot toward me, please? And can you roll so that you're laying on your side facing away from me? Thank you. I'll now remove the sheet from the bed that was soiled, wrapping it into a ball. And I'll go place this in dirty linen. Now I'll unroll the clean sheet and secure the corners on the mattress. As I do so, I'll make sure to stretch the sheet so that it's flat and minimize the wrinkles that are underneath the patient. Okay, Mr. Jones, can you come back onto your back, please? And scoot to the middle. Thank you. I'm now going to place the top sheet over you. And I'll remove that bath blanket now. We'll roll it in a ball and place it in dirty linen. Now I'm going to secure the sheet. I'm going to lift the mattress and smooth the sheet down so that it's flat under the mattress on both sides. Now I'll make hospital corners by lifting the top edge of the sheet about a foot from the end of the mattress, straight up. It'll form a triangle. Everything else will get tucked underneath. I'll repeat that on this side. And I'll loosen this over his toes so he has some wiggle room. There, how's that, Mr. Jones?
Perfect. Thank you.
Very good. I'm going to remove the pillow from under your head. I'll bring it right back. I'll remove the pillowcase Being careful not to allow it to touch my uniform, and lay the pillow on the overbed table. We'll place the pillowcase in dirty linen. I'll take the clean pillowcase and scrunch it up all the way to the edges. We'll put the tag side in, place the pillowcase on top of the tag side of the pillow, and pull the sides down. I'll now place the pillow under his head with the opening facing away from the door. How is that, Mr. Jones?
Perfect. Thank you.
Are you comfortable?
Yes, ma'am.
Here's your call light. If you should need anything at all, please don't hesitate to call. Can I get you something like a magazine?
No, thank you.
Okay, I'm going to open your curtain and wash my hands. The barrier will be thrown away. After washing my hands, I'll think about the steps of my skill, make any corrections, and tell the evaluator my skill is done. All right, any questions on that? Any questions? Let's go ahead and take our break. When we get back, we're going to do a range of motion, which is actually a very short skill. We already know how to do range of motion. We're just going to learn to do it on a different body part. It's going to take us about 3 minutes, and then we'll get into blood pressure. Go ahead and take your break. Thank you.
I'm off Wednesday. Oh, that's good. And Tuesday. Tuesday, I have to look real good. Wait, please look. You know, tonight's chapter, I might read tonight after work. Let's see how much work this is. It should be just be chapter 4. Doesn't say it's for 20 pages. Chapter 30. Are you kidding me? No, don't say that. And the next one's even worse. Like this next Wednesday. Kidding me? Are you? I'm gonna fail this class now. Yeah, I didn't think so. I quit working and just read. Yeah, usually go out. I would go out if that gives me. I would for days. I worked 2 days. That's fine. Oh, you do that. Yeah. I'm gonna set schedule. Yeah, that's worse. I can choose when I work. It's just I need less money. Yeah, that's true. But like, it's like being able to get school done. I have to go. What about the phone? I was asleep. This morning, I didn't go to sleep. I was last night and this morning. The night before today, I slept all the way till I slept all the way till 3. I haven't slept since I was in middle school, like in the middle of summer. What happened when I just turned drunk? I would go to bed at 6 or 7 p.m. and then wake up around 1 or 2 in the morning and then stay up all night watching TV or some scene videos. I don't understand. And check like just make it right and blue and leave it. You're too spicy. Please don't say it. I was looking at next Monday. Next Monday. Hey, at least next Wednesday is easy. This isn't except we have more. Okay. Pages. This was beside the point diet. So let's see. We did. We did one. We did. We did one. Did you do another? Did you do alcohol and risk? Blood pressure? Washing dishes? And then basically, and really good. Women, yes. BP principles.
That smells good.
All right. Is this the one that you needed?
Yes.
You're welcome. Okay. All right, so now we're going to learn range of motion. This is going to be on page 78 of your book. So there's nothing new to learn here. We know all the principles. We know how to do range of motion. So there's really nothing new to learn here. We're just going to apply all that to a new body part. Pretty easy. Along the bottom, you can see somebody with your level of experience should be able to do this in 4 minutes or less. It'll be done on a live testing student. That could be you. That person will be laying in bed. Charting is not required. I have a video on this. The steps are pretty easy. And here's our care plan at the top of page 79. Care plan says provide the following range of motion exercise to the resident's right elbow and right wrist. Flexion, extension. Provide 3 repetitions of each exercise, and the resident's not able to help with the exercises. So let's talk about range of motion for a second. There's 2 different kinds of range of motion. There's active and passive. Active means we tell the patient what to do, but they actually do the work themselves. We just make sure it's being done right. Passive is when the patient can't do the work themselves, and we are going to move their body parts for them. So in this case, it tells us our patient cannot do this themselves, so we are going to do it. That makes it passive range of motion. The care plan tells us what body part to work on. If you look at the care plan, it says the resident's right elbow and right wrist. It tells us the exercises that we need to do, which are flexion, extension, and it tells us the number of repetitions. So flexion extension was up, down. Now, when I do skills on patients, I like to put it in actions that they are familiar with, that they understand. So I would say, I'm going to bend your wrist up to your shoulder like you're making a muscle. Okay. Every 7-year-old boy knows how to make a muscle, right? So most people are familiar with that motion. On the wrist, flexion extension is up, down. So I would tell them, I'm going to bring your wrist forward and back like you're revving a motorcycle. Forward and back like you're revving a motorcycle. So when you put it in actions or movements that they're familiar with, it takes the fear out of it. Your patient will think, oh yeah, I can do that. Otherwise, if you don't do that, if you just say, I'm going to do flexion extension on your elbow, they're going to be like, is that going to hurt? What does that mean? And the anxiety goes up, and your patient will probably be way more resistant because they fear pain. If we give this to them in terms that they understand, it helps relax them out and makes them much more compliant and easier to work with. And ultimately, that makes your job so much easier. So a little bit of description for this skill goes a really long way. Does that make sense? Okay. So there's not much here to go over. It's actually pretty easy. 4 minutes to do this entire skill. Here's our care plan. We're going to provide the following range of motion to the resident. Well, in this case, it's the right elbow and wrist. Remember, the care plan tells you which body part, which exercise, and the number of repetitions. Flexion extension is up, down. Abduction, adduction is side to side. Rotation is around. We're only going to do the motions that the care plan tells us to. We always support the joints from below with a flat palm. We've heard that before quite a bit. We're going to move slowly and smoothly, return all the way to the start position. We're going to ask about and monitor for pain or discomfort during the skill. Every skill starts with the opening. Every opening starts with a knock. And we're going to perform all of the steps of the closing at the end. So you put all of that together. You end up with knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to do some exercises on your right elbow and wrist. Is that okay? I'm going to close the curtain and go wash my hands. When I return from washing my hands, I'm going to bend the elbow up and back 3 times. I'm going to tell the patient what I'm doing, but while I'm doing it, I'm going to move slowly and smoothly, keeping the elbow on the bed and returning all the way to start. We'll do that 3 times, monitoring for pain. Then I'm going to bring the arm up, keeping the elbow supported on the bed. I'm going to make a loose fist, and I'm going to bend the wrist forward and back like they're revving a motorcycle 3 times, slowly and smoothly, all the way to start, monitoring for pain. And then I'll end the skill. Thank you very much, Miss Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Environment's clean. Bed is in the low position. Patient is covered. Open the curtain. Here's your call light. If you need anything, let me know. I'm going to go wash my hands and end my skill. That's the skill. Super easy. I would want this skill during the state exam. So this one I'll do live for you. I need somebody to come over here and lay down in bed. I can show you the video if you want. The video has good close-ups if you'd rather see it, the video. I need to move this over here just a little bit. There we go. All right, so this is not my first skill today. I've done other skills. Remember, on the care plan, you're going to do the skills in the order that they're listed, and you're going to wash your hands at the beginning and end of the first skill. After that first skill is over, the evaluators will tell you you can simulate hand washing during the test. So this is my 3rd skill. So I'm going to simulate hand washing for this skill. I'm going to show you how that works. Here we go. Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? Great. I need to do some exercises on your right elbow and wrist. Is that okay? I'm going to close your curtain. Let me go wash my hands, and I'll be right back. My hands are clean. I've just washed them. All right, Miss Jones, I'm going to do all the work. All you have to do is let me know if there's any pain or discomfort as we do this, okay? First thing I'm going to do is bring your arm up to your shoulder and back down like you're making a muscle. So we're going to turn the hand palm up. We're going to go up and all the way back to start. Feel okay? Up, all the way down. One more. Up, all the way down. Feel all right? Okay, now we're going to move on to the wrist. We're going to bend your wrist forward and back like you're revving a motorcycle. So loose fist, forward and all the way back. Should feel a little stretch. Feel okay? Forward and all the way back. Still okay? One more. Forward and back. Good. Are you comfortable? Is there anything else I can get for you while I'm here? Would you like a magazine before I go? Okay. Your environment's clean. Bed is in the low position. Call light is stuck. There you go. Call light is right there. If you need anything, just let me know. I'm going to go ahead and open the curtain. I've washed my hands. My skill is done. Thank you. Any questions on that? A lot of people online really dread I don't know why, but they really dread range of motion. I like range of motion. I think it's one of the easier skills. Just remember to follow the care plan. As long as you follow that care plan, range of motion is super easy. Okay, good. All right, we're going to get into blood pressure now. Go ahead and pull out your blood pressure cuffs and stethoscopes. That's okay. That's okay. Okay, a word of warning before we get started. Please do not inflate your cuffs. Do not inflate your cuff. Some students try to get a little ahead of me. If you inflate your cuff without it being wrapped around something, you can destroy your cuff. So please do not inflate your cuffs. We're going to go through this step by step. I guarantee you're going to learn something that you did not know before today, even if you know how to take a blood pressure. There are some steps that aren't commonly covered when people learn how to take a blood pressure. So I need you guys to stay with me throughout this entire lesson and not try to move ahead. Okay, those of you who need to put your cuffs together, just hold off a few minutes. I'll help you with all of that in just a minute. But let's learn a little bit about what a blood pressure is before we learn how to take it. So page 56 is the notes for this particular lesson, and we've seen this before. Do you guys remember pulse? Right? We've seen this before. Our heart squeezes and pushes out a wave of blood. That wave pushes the one in front of it, and that wave pushes the one in front of it. And if you remember, we counted these waves because we felt them as thumps under our finger. We counted the waves when we did pulse. With blood pressure, same waves. What we're interested in now is not how many waves there are. We have pulse for that. That's not what we're measuring here. What we're measuring is when that wave moves through, the artery has to expand around it. How much pressure is inside that artery when the wave is moving through? And how much pressure is inside the artery in between the waves? So this, when the wave is moving through, is our top number, also called a systolic number. In between waves, when the heart is at rest, that is the bottom number, or the diastolic. And we have normal values here. For the top number, your normal value should be between 100 and 119. Somewhere in there is considered normal. For the bottom number, your normal value should be between 60 and 79. This is in your book on, let me go back a page here, on page 57 at the top of the first column. So the best way for me to describe this to you is to think about a garden hose attached to a faucet on the outside of your house. If you go up to that faucet and you turn it all the way on, water comes through the hose. The hose expands and gets hard because there's water inside of it. Increased pressure, water pressure in this case. If you turn the faucet off, the water stops flowing. It goes down to a trickle and the hose gets softer, less pressure inside the hose. So if you stood there at that faucet and you went on, off, on, off, on, off, on, off, on, off, on, off, at the other end of the hose, you would see spurt, nothing, spurt, nothing, spurt, nothing. Guys, got that visual? Okay. That is exactly what's happening in the body, except instead of water, it's blood. The heart squeezes, pushes out a wave, and then it rests, it stops, and there's no contraction. The blood kind of trickles. and then another wave, and then more trickle, and then another wave, and then more trickle. And what we're trying to do is just see how much pressure is in there when that wave is moving through. How much pressure is in there in between waves. Now, let's go back to our hose for a second. We've got a hose attached to a faucet in the Florida sun. We turn it all the way on and never turn it off. So that hose is expanded. It's under constant internal pressure. It's got external stress from sun and weather. How long do you think that hose is going to last? Probably not very long. A couple years, maybe. And eventually that hose is going to split from the pressure. In the body, we call that an aneurysm, or in some cases, a stroke. But when you have increased internal pressure that doesn't ever let up, and you've got external stress acting on it, that hose will fail. Does that make sense? It will. Well, in our bodies, if we have high blood pressure, so internal pressure that never lets up, and external stress, that's society, right? We are covered in stress. There is nobody that's not stressed, right? So if we have increased internal pressure and external stress, that's a bad combination. So if we can find high blood pressure and let the nurse know, then we can get medications or other interventions to lower the blood. We can't do anything about the external stress. Stress is stress. That's life. But if we can lower the pressure inside the arteries, we might be able to extend the life of those arteries. Does that make sense? That's why we get concerned about high blood pressure. Now, as a CNA, our job is to just look for high blood pressure. We're going to take blood pressures, and if we find a high one, we're going to report it. Now, remember that CNAs do normal. Do you guys remember me saying that? CNAs do normal. If the patient already has super high blood pressure, that is not normal. Who would be taking those blood pressures? The nurse. That's right. So all we're doing is trying to find a high blood pressure to report. Any questions? No? So in order to do this, we're going to inflate the cuff, and we stop somewhere between 160 and 180. This is where we stop because we do normal. Anything beyond there hurts, like really bad. What effect do you think pain has on blood pressure? What do you think pain makes blood pressure do? Makes it go up. So if we're hurting the patient and we get a high blood pressure, was it really high? We don't know. Maybe it was high because we inflicted pain. So as CNAs, we don't go past 180. That is our stopping point because we're just looking for somebody that has a problem that we can report. We're not looking to see how bad the problem is. That's nursing. Nursing has to figure out how bad the problem is. We're just trying to find a problem. So as CNAs, we go up to 180. That's it. And then we deflate the cuff by decreasing the amount of air in the cuff. We deflate the cuff and that needle starts to move down. When that needle starts to move down, we are going to listen using a microphone. Let's go back here. What I'm listening for is a wave of blood hitting the top of an artery buried under muscle, fat, and tissue. This is not a big sound. This is a little sound. A wave of blood hitting the top of an artery. Little sound. I need a big microphone to pick that up. And that microphone needs to be in the right place. Good? Everybody with me? So we're going to inflate to somewhere up around 180. We're going to deflate. And while it deflates, we're going to listen. And what we're listening for is the first thump that we hear. So that means if it's the first one we're trying to find, there's nothing before it. Quiet, 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 still quiet, quiet, thump. There it is. Now, your brain will try to talk you out of this. Your brain, you'll go up to, you'll go up to 180 and you'll start to deflate. And it's quiet. Still quiet. And you'll go, I don't hear anything. Something's wrong. I don't hear anything. There's no thumps yet. You gave up before the thumps started. Because if we go back here, if we go back here, where is it? My top number ideally shouldn't show up until somewhere around 100 to 119. Let's go back here. There's a whole lot of quiet between 180 and between 100 and 119, right? So this right here is where I should hear thumps. There's a whole lot of quiet there. Don't let your brain talk you out of this. Okay? So we inflate, we deflate. It's going to be quiet. We're listening for the first thump. Now, when we hear the first one, we're going to hear more because the first wave was able to make it through. So you're going to hear more. Thump, 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 thump. We don't care about those. We're not counting them. We're not measuring them. They have no bearing on us whatsoever. What we're listening for is the last clear thump. So we inflate our cuff to around 180. We deflate the cuff and it's going to be quiet. And then you're going to hear your first thump. Where the needle is, when you hear the first thump, the number that it's pointing to is our top number of our blood pressure. We're going to hear more thumps. We don't care about those. Thump, 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 don't care. Thump, 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 thump. What we're listening for is the last clear thump. But the problem is that last one can be really tricky to pick up because you won't know it's the last one until none others come after it. It doesn't say, get ready, get set, here I come, ta-da. It doesn't do that. It just goes thump, 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 thump. Oh, that one was the last one because there weren't any more, but you won't know it's the last one until there's nothing after it. So you guys got that? Some of you are going to have trouble with the top number. You are my dreamers. If you have trouble with your mind wandering, going and picking flowers when you're trying to concentrate on something, you're going to have trouble here because you get up to 180 and it starts to come down and it's quiet. There's nothing going on. You're waiting for the first one. So your brain starts to do strange things like I'm hungry, thump. I don't thump, no, thump. What I should thump, have for thump, lunch, thump. Oh, where did it start? I don't know. Okay. So some of you are going to have trouble with the top number. You've got to, this is where practice comes in. You've got to train your brain not to go out and pick flowers. You got to focus on what you're doing. Now, some of you won't have any trouble with the top number. Some of you will have trouble with your bottom number. Now, you guys are my dancers. Okay, you're not my dreamers. You're my dancers. Now, what happens here is that rhythm-oriented people will get into a rhythm. Now, our heart beats on a rhythm, a regular rhythm for most people. And your brain will get into that rhythm. How many of you guys filled in that next beat? If you filled in that next beat, you are going to have problems on the bottom because you're not going to be sure. Was it a beat or did I think there was a beat? I'm not sure. So some of you will have trouble with the top number. Some of you will have trouble with the bottom number. And some of you, like me, will have trouble on both. When I first started learning blood pressure, it wasn't explained to me this way. It was just, here's a stethoscope, here's a blood pressure, inflate, deflate, listen for your sounds. That was it. That was all the instruction that we got. And then it was practice. Practice what? I don't know what I'm doing. And it took me a long time to figure it out. And I had to go to other nurses and say, I need help here. I'm not getting this. So that's why I go through every part of this in detail, because I don't want you to get home tonight and go, well, I don't know what I'm doing. I don't know how this works. So we're going to go through this whole thing in detail so that you understand what we're doing here and what these readings mean. Good? So if we inflate the cuff and deflate the cuff and we listen for the first and last sound, if we get the first sound here and then we hear more thumps, thump, 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 and then this is the last thump that we hear and then it's quiet all the way back to 0, this is our top number where we heard the first thump. This is our bottom number where we heard the last clear thump. And that's all a blood pressure is. We're going to use 2 pieces of equipment to make this measurement. We're going to use a blood pressure cuff and a stethoscope. This has an actual name. It's called a sphygmomanometer. I don't expect you to remember that. We call it a blood pressure cuff, but it does have a name. And this is where we're going to start, is with your blood pressure cuff. So if you have a blood pressure cuff with you, go ahead and open it up. If you need to put it together, I will come help. Does not matter which one the gauge and the bulb go into. You just try to push them in as far as you can. Got it? Got it? Got it? Okay. So you're going to put your gauge in there. Got it? Anybody else need my help? Nope. Don't get ahead of me. Nope. Nope. Don't get ahead of me. Don't inflate. Don't get ahead of me, guys. Okay, there's a couple things on here that we need to discuss. We have a fabric tab. We have a white stripe. We have Velcro. We have a bulb, and we have a gauge. These are going to be all very important parts of what we're doing. So the bulb and valve assembly is how we inflate and deflate our cuff. When you hold this in your hand, you're going to hold it where the ball is in your palm and that dial is between your thumb and index finger, just like this. Do not hold it like this. It needs to be held in your palm and that dial in between your index finger and thumb, just like this. Okay? You're not going to let go of it. This is what it should look like. The bulb is in my palm, dial in between my thumb and index finger. Super important that you hold this the right way. Faith, just stay with me. I'll show you how to do it. All right, so the dial is going to turn to open and close the valve. This is how we're going to push air into and take air out of that cuff, is through that dial. That is our open and close, just like the faucet, right? You open the faucet or close the faucet, same thing. But here's the trick. Remember righty-tighty, lefty-loosey. When you when you close it, when you turn it to the right to close it, put air into the cuff, don't tighten it. Don't crank it so that it's really tight, because in just a second, we're going to have to loosen it. And this is like the #1 reason that people miss taking blood pressure. If I tighten that really tight, when I go to loosen it, I'm going to have to give it a lot of oomph, and it's going to let out way too much air. And my needle's going to go, woo, and I'm not going to hear anything. So we just close it until it closes. Don't tighten it. Okay. So once we close that valve, we're going to pump our bulb. until that needle gets up to about 180. Now, with these cuffs, this is not a one size fits all. It's one size fits most, but not all. This stripe right here on the professional cuffs, you have a stripe on one edge. So those of you who have a bar, a metal bar on your cuff, you're not going to have this because those are not professional cuffs. Those are home cuffs. So professional cuffs will have a white stripe. And what this white stripe is a measuring guide. It allows you to figure out whether this cuff is going to fit your patient. So can I borrow you for a second? So if I have a cuff and I'm concerned that this cuff may not fit her arm because her arms are a little bit smaller, and if I use the wrong size cuff, I'm not going to get an accurate reading. So if I'm concerned that this cuff may not fit this patient, what I'm going to do is take this white stripe, I'm going to have her hold her arm out, and I'm going to put this stripe underneath her arm about an inch above the elbow. I'm going to wrap it around the back of her arm, just like this. If I can't see both corners, it's too small for her. If it wraps more than halfway around her arm, it's too big for her. This cuff is perfect for you. Okay, you can have a seat. So this stripe is designed to measure whether this cuff is going to work on each patient. If you're concerned, if you aren't real sure, measure it. Because if you take a blood pressure with a cuff that's the wrong size, not only will it not be accurate, but it will cause pain in your patient because it's not distributing that pressure equally. And you'll end up with a patient that hurts. Now, this gauge is heavy. Feel how heavy that gauge is. If that gauge, it's got some little prongs on the back. If you just kind of hang it there, when you put this cuff on and take it off of your patient, this gauge could fall. It's heavy. And what it's going to fall on is your patient's wrist. That's what's right there. It's going to fall on your patient's wrist. If your patient has osteoporosis, you will crush their wrist with this. You'll crush it. So when you put a cuff on and take it off, this gauge should be firmly attached to your cuff. That's what this fabric tab is for. The back of the gauge has a little clip. If you press down on the bottom of the clip, the top magically opens. So the tab, you're going to open your clip and slide it up the tab, and it's now firmly attached. It's not going to go anywhere. Now, those of you who have a metal bar on your cuff, you want those are designed to be home cuffs to take your own blood pressure. So you're not going to have a lot of this because it's not designed to be used on other people. So some of this stuff I'm talking about, you may not have. It's fine to practice with. You guys are fine to practice with it, but you'll probably want to get a professional cuff once you get into the field. All right. So when we're taking the blood pressure, we're going to turn our gauge to the right just until it stops. We're going to pump our bulb until the needle gets up to about 180. And then what's happening inside the body when we're doing that, when we pump up that gauge, when we put air in, the cuff is on the arm and it's going to surround an artery that goes down the middle of your arm. That air that we're pumping in is going to put inward pressure. And when it does that, it's going to use the muscles to close off that artery. We're literally closing the artery. Now, when we close off that artery, the heart is still pumping. Better be. Otherwise, it's got way bigger problems. The heart is still pumping, but that blood can't get to the bottom of the arm. We've closed the road. So you don't want this to take a long time, right? Patient has no blood to their hand. We don't want to take this a long time. So as we inflate, when we're at 180, we're closing off, using the muscles in the arm, that artery. Now, as those waves are being produced by the heart, they're going to kind of stack up, waiting to get through. but they can't make it through because we've closed the road. So as we turn this dial counterclockwise or to the left, we're going to decrease that amount of pressure. We're letting some of the air out. And as that cuff deflates, that needle's going to come down slowly. You are in control of that needle. If that needle goes too fast, that's you. If that needle stops, that's you. This dial right here is how you control that needle. If you open it too much, that needle's going to go, woo! If you don't open it enough, that needle won't move. It'll just stay there. We are going to try to get that needle to move in a nice, slow, consistent rate all the way to 0. So what it should look like is the second hand of a clock going in reverse. That's about how fast it should be going. Okay, so take a look at the clock right up there. That's your speed that you're going for. Any faster than that, you opened your dial too much. Any slower than that, you haven't opened your dial enough. You're in control of this. So as you deflate the cuff and the needle starts to come down, that pressure is relieved on the inside and the artery starts to open up a little bit. As the artery starts to open up, eventually waves of blood are able to push their way through. And when those waves push their way through, we have a microphone that we're going to put right over that artery so we can hear when that first wave is able to make it through, because it's going to hit the top of that artery right under our microphone. And we're going to pick it up. And that's our first thunk sound. Now, we've got waves. They're moving through. So as we continue to decrease the pressure, the artery gets bigger and bigger and bigger and bigger. So lots of waves are going to get through. We're going to hear all kinds of thunks. The first one is the one that counts. We're going to hear more thunks. We don't care about those. Wherever the needle is when we hear the first thunk is our top number. And then we're going to hear more thunks. We don't really care about those. But eventually, this artery is going to get so big, right, because the pressure is off of it, it's going to get so big that we can't hear the wave of blood hitting that top of the artery anymore. It goes quiet again. That last thunk that we hear, the last one where a wave of blood hit the top of an artery, that is our bottom number. Because from then on, the waves are just moving through just fine. They're not hitting the artery. Does that make sense? We're going to inflate the cuff, deflate the cuff, listen for the first thunk and the last clear thunk. This is what's happening inside the body while we're doing that. So the last thunk sounds means there's no more after it. This last one is your bottom number of your blood pressure. So the number where we heard the last thunk is the diastolic blood pressure reading, or bottom number. This person's blood pressure was 118/78. So let's see how we get these numbers. Make sure you keep deflating until the needle reaches 0. Now you can remove your cuff and record the readings. So the number where we hear the first thunk is our top number. The number where we hear the last thunk is the bottom number. And we need to learn how to read this dial. So if you look at this dial, it's the same one that you have on your cuff. When you look at this dial, let me come over here. You're going to see numbers all the way around in 20s. So we have 20, 40, 60, 80, 100, 120, 140, 160, 180, 200, and so on. The big lines in between are 30s. They're not marked, but they're your odd numbers. So if this is 20, that is 30, 40, 50, 60, 70, 80, 90, 100. The little teeny tiny lines, those are 2s. Hold on, I'm ahead of myself. I'm always ahead of myself. The teeny tiny lines are 2s. So if this is the line for 140, we have 142, 144, 146, 148, and there's our line for 150. Good? Any questions? Okay. Faith, we don't deflate to 160, 180. We inflate to 160 to 180. We don't go over 180. That's not the role of the CNA. The nurses would have to do that. So we're going to inflate slowly, or we're going to inflate to 160 to 180. We're going to deflate slowly. Listen for the first thunk, which is our top number, the last thunk, which is our bottom number. Deflate to 0 and document. This is not a hard skill. That's it. That is blood pressure right there. If you ask any medical professional how to take a blood pressure, this is what they're going to tell you. Okay. This takes practice, though, because there's a lot going on. Your hand has to control the bulb and valve assembly. Your eyes have to watch that needle and figure out what number the needle is pointing to. Your ears have to listen for the thunk sounds. And your brain has to put all of that together that quick. So this is going to take a little bit of practice. It takes about 45 blood pressures before you even start to get accurate. So we inflate, we deflate, listen for the first thump and the last thump. So knowing what we know now, if you look at this, we heard the first thump here. This is our line for 100. Little ones are 2s. So 102, 104, 106. Okay, so our top number is 106. We heard more thumps. We don't care about those. Thump, 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 thump. Here's our last thump that we heard. If this is the line for 60, 62, 64, 66. So 106 over 66 is our blood pressure. Good? Questions? We still have a long way to go. We're not there yet. This is just one part. Now we have to learn about the stethoscope. So you have a stethoscope. Some of you have a double tube stethoscope like this. Some of you have a single tube stethoscope. Either way is fine. But your stethoscope will have an end on it. Some of you have 2 sides. Some of you have a single side. Those of you who have 2 sides, I'm going to talk to you guys first. Okay. If you have these flat discs are called diaphragms. These cups are called bells. You might have a diaphragm and a bell. You might have 2 diaphragms. Doesn't matter. We don't use this side. Doesn't matter what you have over here. We need a big microphone. We're going to use the large side. The problem is that this stethoscope, it doesn't know which side you need. You have to turn the side on that you want to listen to. This whole thing flips around. The whole thing turns. For those of you who have a 2-sided stethoscope, you probably have a little dot on one side. That dot is your on side. You want to make sure your large diaphragm is facing the same direction as that dot. If you don't have a dot, you may have a flat bar. One side is curved, one side is flat. The flat side is your on side. Littmans sometimes don't have dots. So you have a single side, so yours, you won't have to turn. Anybody with a single side, you won't have to turn. Did you find your dot? Do you have a dot? Okay. You have a dot? Okay. Okay. You got a single side. You've single, were you able to find yours? Dot? Okay. Anybody have trouble finding their dots? Single side? Okay, good. Good. Okay, so this is essentially a microphone. So some stethoscopes have 2 diaphragms. Others are single. They don't turn. But what we're looking for here is a dot. We want the large diaphragm to be facing the same side as the dot. So this is in the wrong configuration. We would want to flip the whole thing over to make it work properly. So the whole thing flips. So again, this is a double tube, or what we call a sprig. You want to look for that dot. Ear tips are the most misunderstood part of a stethoscope, though. This is important because you've got to listen to the right side, but this is critical. And this is the part I don't know why everybody gets wrong. When you put these in, okay, some of you, your ear tips are already pre-set up for you, which helps. Ear tips are what we're talking about right now. We have to transmit this sound directly to our eardrums. So some of you have ear tips that are already pre-set up for you. If your ear tips are straight like this, that is not how they should be configured. So we need these ear tips to face slightly forward. To do that, we're going to hold down here at the little chin strappy thing, and we're just going to reposition those ear tips a little bit in the forward direction. Some of you already have yours set up. If they're already kind of in the forward direction, you don't have to do anything. If they're not, I'm going to come around, then we have to yours are already set up. There we go. You have no stethoscope? Okay, it's fine. There you go. Yours are set up. Oh. Yep. Good job. There you go. All right, when you put these in your ears, how they face actually matters. So when you put these in your ears, okay, we have a curve to our stethoscopes now, our ear tips. When you put these in your ears, they need to face forward, not backward. So we've already done that. So do you see how this faces forward? Not like this. So I want you to take your stethoscopes, make sure your earpieces face away from you, and put them in your ears. Take yours out, flip the whole thing around. There you go. Yep. Put these in your ears and then tap your diaphragm. Tap your diaphragm. Can you hear it? Everybody hear it? Take your ear tips out, turn the whole thing around, put them in backwards, and then tap your diaphragm. Can you hear it? Okay, not as clear, right? Remember that we are listening to a wave of blood hitting the top of an artery buried under muscle, fat, and tissue. We need the best microphone, and we need it to funnel that sound directly to our eardrums. So when you put these in, they must face away from you. Now, when you're in here practicing in just a little bit, some of you are going to get this wrong. And as I'm walking around, I'll remind you, turn your stethoscope around. It's got to face forward. Okay? Good? Okay, so putting in the ear tips in the wrong way is a common error. Now, the thing about blood pressure is you have to know, as a healthcare professional, you have to know how to take a manual blood pressure. Everybody has to know how to do this. It's not on the state exam. This is not a tested skill. You will not have to demonstrate taking a blood pressure for the test. But that doesn't mean you don't have to learn it. Okay. Take the testing pressure off. But guys, I might be the body in the bed one day. And I have serious blood pressure issues. And if you're taking my blood pressure and you're not doing it right, I'm the one that will probably suffer for that because I'm not going to get the treatment that I need. Okay. Good. Okay. So we're going to inflate up to about 180. We're going to deflate slowly and smoothly. We're going to listen for the first thunk. Where is the needle? When we hear that first thunk, that is our top number. We're going to hear other thunks. We don't care about those. We're listening for the last clear thunk. Where's the needle when we heard the last clear thunk? And then we're going to deflate all the way to 0. Where you heard the first thunk is your top number. Last thunk is your bottom number. Okay. Clear? Kind of? Okay, let's go to page 57. Now, these thunks actually have a name. They're called Karatkoff sounds. You don't need to know that, but you may see it on the state exam. It may say something about you heard Karatkoff sounds. So I just want you to be familiar with the term. I call them thunks. It's easier to say. When it comes to taking a blood pressure, though, there's a couple of variables that we need to keep in mind. First of all, if you remember, we talked about pulse, not having the patient's arm hanging out in midair because it's going to increase the pulse rate. It will also increase the blood pressure. So when you're taking somebody's pulse, their arm really does need to be supported on something, not hanging out in midair. Okay. Where you listen matters. We are listening for a wave of blood hitting the top of an artery. If you aren't over the artery, you're not going to hear it correctly. And the artery is not where you think it is. So if you hold your arm out, those of you with jackets, you'll need to take your jackets off. You hold your arm out and get that elbow popped all the way up. So you really want this nice straight arm at the fold of your elbow where the lines are. On the pinky side this time, we're going to put 2 fingers, not our thumb, but 2 fingers, thumb on the back. It's not in the middle. Everybody tries to go in the middle. It's not in the middle. It's on the inner aspect. See if you can find your thumps. And you'll notice it is not in the middle. It's on the inner part of your elbow. So if I have my stethoscope in the middle, I may not hear when those thunks actually occur, which means that my blood pressure reading is not accurate. Got it? Now, if you're having trouble finding it, make sure your elbow is straight. We got to pop that artery all the way up. All the way up. You're too far over. Come on the inner aspect. Keep going, keep going, keep going, keep going. There you go. Did everybody find your thumps? Everybody find your thumps? Were you able to find it? Okay. So we want to be on the inner aspect. So inside. There. Feel it? Press a little harder. Harder, harder, harder. Got it? Find somebody else's artery. You can turn around and work with her. Remember, it's on the pinky side. Make sure that elbow is popped up straight. If you don't have a straight elbow, that artery sags down, you can't feel it. So now what we used to do is we used to take a pen, we would find the artery, and then we would just do like a little X marks a spot, right? So our patients really didn't want us writing on them. They thought it was a little weird. So on your blood pressure cuff, you actually have a tab that says right arm, left arm with an arrow. Or you might have a line with a circle in it. That is your artery mark. This cuff does not have a brain. You can't put a cuff on and say, oh, that must be where the artery is. That doesn't work that way. What you're going to do is lay the cuff on the patient's arm, not yours, the patient's, but you're going to lay the cuff on the patient's arm. You're going to find the artery with your fingers, and then you're going to line that arrow up with where you find the artery, and then you're going to secure the cuff so that it's snug against the arm. So the artery marking is built into your cuff, but you have to find the artery first and then make sure that marking is pointing to it. And that tells you where to put your stethoscope once you're ready to take the blood pressure. Now, when you're using the stethoscope, don't put it under the cuff. I'm wearing a microphone here. The people virtually can hear me because it's clear. It's in the right spot. It's right under my face. They can hear me. But if I did this, if I put something over that microphone, now what they hear is very muffled. It flattens the sound or deadens the sound. This is a microphone. If you put it underneath the cuff and we inflate that cuff, it's going to deaden the sound, flatten it out, and it's going to be very hard to hear. And chances are you're not going to hear where the thumps actually occurred. Make sense? Good. Any questions so far? All right, so if you're looking on page 57, oh, one other thing. With patients, their feet really should be flat on the floor when you're taking a blood pressure. You want to ask which arm or look at the care plan to figure out which arm you want to use, but their feet should be flat on the floor. So if we want to look here in this gray box, remember the gray boxes are always knowledge check questions. Make sure that you understand the concepts that I'm teaching. Look at number 8. Okay, we've got a little graphic here that shows where we heard the first thunk and where we heard the last thunk. And I know it's small and a little blurry and hard to read. I get all that. Do your best. Ballpark is good. If you look at that, where did we hear the first thunk? Everybody good with 130? Okay. Where did we hear the last thump? 90. So what is this patient's blood pressure? 130 over 90. See how easy that is? Is that a normal blood pressure? No, because normal on the top is 100 to 119. This is 130. Normal on the bottom is 60 to 79. Which one? What was this? 90. So what would we do with that information? Report it to the nurse. Very good. Now let's go to number 10. Again, you've got a graphic with indications of where we heard the first and last thump. So, and I know it's blurry and hard to read, but can somebody tell me about where we heard the first thump? 108. Okay. Where did we hear the last thump? 62. So what is this patient's blood pressure? 108 over 62. Do you guys see how we got that? Easy peasy, right? Yeah, we got to put all these pieces together, though. We got to listen with our stethoscopes and control it with our hands and get our brains involved and our ears and our eyes. And it gets a little more complex than just on paper. So it's going to take you about 45 blood pressures to get accurate at this. We're going to practice in here in just a few minutes. I'm going to sign off of online first because they don't need to see practice. All right, so any questions on blood pressure? Any questions? Not too bad, right? Okay. All right, so remember, I'm signing off of online, but remember for you guys, you have chapter 4 to read between now and Wednesday's class. Your test is on page 184, and you're going to grade it using the answer key on page 201. I'll look at your wrap-up emails here in a few minutes and get those set back up. The replay of today's lesson will be in there. And if you haven't joined the online course yet, you probably want to do that. Okay, it will be very, very helpful for you. So I'm going to go ahead and sign off. For those of you attending virtually, remember that you can access the worksheets on flcnatraining.com. So let me put that in the chat for you. The worksheets are there. They're free. And they will help you wrap up everything that we learned in class today. I'll pass them out to you guys in just a moment. So make sure that you tune in tomorrow for the game show. I've got the game show tomorrow morning at 11 a.m. Eastern. We'll go over 15 test-like questions and all award prizes. So join us for that. Other than that, we will see you on Wednesday. Until next time, happy caregiving. Bye.